When we talk about respiratory tract differences in children and we look at the anatomy and physiology of the respiratory system, there are some definite differences between the child and the adult. Thinking about those respiratory tract differences, the frontal and sphenoidal sinuses don't actually develop until about 6 to 8 years of age. Tonsillar tissue, what do you think it looks like, especially in early school age children compared to the adult? Hopefully you're thinking it looks enlarged. They have, for your blank, they have enlarged tonsillar tissues, especially in early school age children. Those tonsils really start to become big around 7 years of age, and very common. Just think about being around other kids. They often share those germs that we don't like with others. They're in close proximity. And one of the big things that we tend to see in this age group, thinking about illness that goes along with why their tonsils are so big, is because we're seeing in school age children a lot of pharyngitis or strep throat, tonsillitis, very common in school age children. And when you think about why would the tonsillar tissues be so enlarged, tonsillar tissue, what's it really doing when you think of respiratory system? What does it act as? Tonsil tissue is acting as a filter for those different viruses and germs and bacteria. It's really acting as a filter. And unfortunately, when it acts as a filter and it's always exposed to different viruses, uh, it's just going to naturally be a little bit larger. So tonsillar tissue is enlarged. And let's talk about the airway for the infant. The infant's airway, think about compared to the adult especially. What do you think that airway looks like for an infant? It's definitely a lot smaller. It's not as wide, which leads to potentially more problems, right, compared to the adult. So the infant's airway itself is shaped like a funnel. It's narrowest at the cricoid cartilage rather than the vocal cords like the adult. The airway itself narrower, which means it leads to increased resistance if there's obstruction or swelling occurs. Even small changes can lead to big respiratory issues or distress for a young child because of that increased resistance. So you can have obstruction from swelling, you could have obstruction from really thick mucus and secretions, or maybe something else going on. Infants also have large occipitates which, compared to the adult, which can also cause airway obstruction. So laying flat can put their head in a flexed position, again, kind of cutting off or obstructing part of that airway. Their tongues are large in proportion to their mouth, which again leads to more easily obstructing that airway. They have small nares and are nose breathers until about 6 months of age. So again, thinking about when they get a respiratory illness and they kind of get stuffed up and they get a lot of mucus, if they are nose breathers, and they're trying to take a bottle or something else where they get stuffed up, makes it a lot harder, right? So nose breathers till about 6 months of age. Again, nasal obstruction can contribute to significant respiratory distress. Their airway structures themselves have greater laxity because they're underdeveloped cartilage in the airway, and the compliant airway can lead to an airway obstruction and even collapse. They have smaller amount of smooth muscle in their airway, which means the infant doesn't develop a bronchospasm readily. Right? That's not something you typically see in the infant. And wheezing may not be the predominant finding in an infant, even when the lumen of the airway is severely compromised. Again, it goes back to that smooth muscle. It goes back to how small that airway is in general. Wheezing is just not that predominant sound. So even though you might not have wheezing, that doesn't mean if they're not having, you're looking for other signs of respiratory stress, but that airway can still be severely compromised even without having wheezing present. Let's talk about how we assess respiratory illnesses in children. Just like in the adult, we do a lot of the same key assessment pieces. So again, build on what you know and include that, and then we'll talk about some differences that we see or things we may need to do differently in the child. So assessment of the respiratory illness in children simply does include just a history taking. Generally, what's their past medical history look like, family history, all of those pieces might be important. Birth history, prenatal history, any of that could be part of that history taking. Of course, we're going to do a physical exam, right? So thinking about what do you assess in the respiratory system when you go assess? Just looking at just respiratory, what would you assess? Here you want to assess their rate and their depth of respirations. What is their effort with their respirations? Are they working really hard? Are they easy? Do they seem labored? Do they have retractions? So, retractions is something you really only typically see in kids. And again, a lot of that has to do just with the nature of like their cartilage being underdeveloped, and just they're a little more, so to speak, flexible. So we tend to see retractions. And then the next slide, I'm going to actually talk about retractions a little bit more and show you some differences. Um, or there's a clip of different types of or distress breathing that you can access. So we look at retractions. We look if they have a cough, and is it productive or non-productive? Is it dry? Is it wet? Are they restless? Are they really kind of anxious and just kind of squirmy? Because that could certainly tell you they're in a little bit of distress or having a harder time breathing. Is there any cyanosis present? So cyanosis, around their mouth. Do they have, going into the next part, clubbing of their fingers? Which, if you're thinking, why would they have clubbing of their fingers? Hopefully you're thinking, well, there's chronic lack of O2, right? So that's just an example. We'll see that in some disorders later on that we go through, some diseases where clubbing of the fingers or nails is possible. What do their breath sounds sound like? Do they have any adventitious breath sounds? Do we have wheezing, crackles, rails, rhonchi? We want to listen for all those things. Those can be helpful in distinguishing maybe what's going on. And of course, we can always look at chest diameter as well when we're doing our physical exam. As for laboratory tests, there's all kinds of things we can do. We always usually start kind of in general, not just with respiratory, but with anything. We always start with the least invasive and work to a more invasive type of laboratory test. We can do a simple one just simply at the bedside, and that's a pulse ox or an oximetry reading and see what their O2 stats are like. We can get a nasopharyngeal culture, see if there's anything growing, or certainly rule out if it's viral or bacterial for different disorders. And in some cases, we might want to send off a sputum analysis and analyze that. And then the last thing, any sort of diagnostic procedures. We could do something as simple as just getting a chest x-ray, see what's going on in there, if there's any infiltrates, any consolidation, or anything that would tell us potentially what's going on respiratory-wise. We can also look at pulmonary function studies, so doing PFTs. We do those a lot, especially with our cystic fibrosis patients. We can do that with asthmatics. There's different reasons we can do pulmonary function tests. So those two disorders we'll talk about later, and they're just a couple examples of why we might do pulmonary function test. And the whole thing is when we're doing all these different assessment and laboratory and physical exam findings, it's really about getting an important and as accurate of a picture as possible, so we can figure out what the problem is. Could it be a result of a variety of different circumstances, or is there maybe just one thing going on? And how do we really target our treatment and our care? So I mentioned before that kids often, or younger kids often, will have retractions. We tend to see retractions in infants, toddler, and maybe some preschool and maybe early school age. It just depends on how severe. You tend to see it more so with infants and toddlers when they get into some respiratory distress. And in the picture that's on your slide, it's showing you 5 different areas where you can typically see retractions. And that could be intercostal, suprasternal, clavicular, substernal, or subcostal. And if you've never seen retractions, it's the best way to kind of describe it is there's a pulling action. So like I'm going to use intercostal because it's a little bit easier to kind of picture what would be going on. So you can see pulling of that muscle between like the rib cage. So that tells you anytime you have retractions, they're working hard to breathe. The airway is compromised. Something's going on. It's either narrowed because of swelling or an obstruction. And if they're having retractions, they're working pretty hard. They may not typically have them in all 5 areas. They're really only going to have them maybe in 1 or 2 places at a time. And again, that just tells you, is it more upper airway? Is it potentially lower airway? How compromised are they getting? Retractions are usually kind of graded as mild, moderate, or severe. So obviously with mild, you just have a little bit of pulling. When you get to severe, you're talking about you've got extreme pulling. If you click on my link that says various distress breathing, it's a bunch of short videos that will show you various breathing in an infant, I believe toddler, and preschool. So it'll just kind of give you an idea. You can see, especially in some of the infant ones, even look at their nostrils. Are they flaring? You can sometimes see, or not see, but you can hear grunting, and you can also see head bobbing in an infant. All of those things tell you that infant is working really hard to breathe. Not a good thing. Because again, kids will typically, if they're going to, for lack of a better word, have any sort of type of arrest, it's going to be a respiratory arrest versus a cardiac arrest, right? So kids can only compensate for so long and work so hard, and then their body's just going to go, I can't take it anymore, and give out. And we don't want that. We want to catch these things ahead of time and do interventions that are going to help improve their distress breathing. Right, this slide's just kind of showing you the different lung sounds that we expect to hear. Again, you can have wheezing, stridor. Stridor is something that you don't typically hear too often in adults. It is something you do hear more frequently in kids. And just like the picture says on the slide, stridor is more of a high-pitched sound, and it usually occurs on inspiration only, and it is an upper airway, or it occurs in the upper airway. It usually tells you there's some sort of upper airway obstruction going on. Again, rhonchi, fine crackles, pleural rub, that's not too common in kids, but it can occur. And then, of course, coarse crackles are the different lung sounds. So if you're not familiar, you can just simply Google. I'm not including a link to lung sounds, but you could simply Google and listen for, or you go to YouTube and listen for lung sounds. Again, most of these things don't sound any different than the adult. Stridor is probably really the only new one. And I also included on this slide just a quick, again, the areas anterior, posterior that we're listening to for respiratory, not any different than the adult, and what you learned way back in assessment or the fundamentals lab. When we talk about health promotion and risk management in children, the common cold is the most frequent respiratory infection or disorder that we do see in children, and it's easily spread through families because they're in close contact with one another, and we see it easily spread even with amongst other children like their friends at school because they're in close contact as well. It is important to teach as young as the toddler age group about good hand washing, how to properly dispose of their tissues, how to block a cough and their sneeze in their shirt, not using their hands, because they're gonna go right back to playing. They're not gonna think about going and washing your hands or their hands unless you say something to them. So again, teaching them to cough into or sneeze into the elbow of their shirt or their sleeve can be helpful as well. We want to make sure we're promoting keeping up with the yearly influenza vaccine that is recommended for all ages, 6 months and older. And if you were in on my Q&A, I talked about 6 months is when we can start doing the yearly vaccine. At that age, it is actually divided into 2 separate doses about a month apart. And then usually once they get past, I want to say it's the age of 2, they can just do one influenza shot a year during, obviously, influenza season. We also want to reduce respiratory irritation by trying to decrease exposure to secondhand smoke. We know that secondhand smoke is very irritating to the respiratory system in general. It helps by reducing exposure to secondhand smoke. That helps prevent URIs or upper respiratory infections. It can also decrease the incidence of asthma attacks and otitis media in children. Getting into therapeutic techniques used in the treatment of respiratory illnesses in children. Some of our home treatment measures that we can use: humidification. We can do that simply even in just a bedroom for a child. There's inhalation devices, so whether that be like an actual inhaler itself, it could be a nebulizer machine. There's different, like I said, different inhalation devices. Those are probably the two most common. Coughing, again, just how to get kids to do a better job of coughing and how we can promote that coughing, and especially with use of like mucus clearing devices. So think of like an incentive spirometer, mucus flutter device, things that are going to help break up some of that mucus. And then, of course, there's also chest physiotherapy or CPT, where you typically kind of not hard, but you kind of either cup your hands or have something else that creates kind of that cup formation, and just simply patting on their back to help loosen up any of that mucus, and then, of course, promoting them to try and cough that out. Also, want to talk about therapy to improve oxygenation. There's all different things we can do. Oxygen is just one means, so oxygen administration, that could be through a mask or a nasal cannula. There are different types of masks that we use, no different than the adult, but you've got your non-rebreather, your simple mask, or just a couple options. We can also look at some pharmacologic therapy as well to improve oxygenation. Incentive spirometry, just some good breathing techniques, so exercises to help them better inflate and more fully empty their alveoli. Endotracheal intubation, tracheostomy, and assisted ventilation. Obviously, those last three are, the more invasive type things. We hope we don't ever have to get to those in different respiratory illnesses, but in the case that we do, those are some other techniques. Right, we're going to start talking now about different disorders, and we're going to start with disorders of the upper respiratory tract. And the first one we're going to talk about is acute nasopharyngitis, which really just means the common cold. Right, so this is the most common that we see. It's the most frequent infectious disease in children. For toddlers, we tend to see 10 to 12 colds per year. In school age, we can see as many as 8 to 10 per year. It's spread easily in classrooms. Again, you're in close contact. Kids aren't always great at washing their hands or making sure we cover coughs and sneezes, and especially using, again, like the elbow or the sleeve versus our actual hands, because even when they do blow their nose or they cough or sneeze into their hand, they don't always remember to go wash their hands before touching things. So again, very common spread. Incubation period for a common cold is about 2 to 3 days, and it occurs most commonly in fall and winter. The common cold or acute nasopharyngitis can be caused by numerous viruses, and for the most part, they're pretty self-limiting. So just a few examples: rhinovirus, RSV, adenovirus, parainfluenza, and influenza are just a few examples. Probably the most common ones that we see. The clinical manifestations you're going to see with acute nasopharyngitis, lots of nasal congestion, of course. They can have watery rhinitis, so runny nose, a low-grade fever that typically only lasts for a few days. So again, low-grade fever, it's more viral. Most often, I'm not going to say there aren't viral infections where they can't have high fevers, but tend to be when you have a viral infection going on, it tends to be a little bit lower grade fever than it does a high grade fever. So that low grade fever, maybe just for a few days and it'll go away. Those mucous membranes of the nose, they're becoming more edematous and inflamed, which just leads to that difficulty breathing. So again, think about the younger child who's got the smaller airway, nasal passages, things like that, how that can become a little more difficult for them. They can have posterior rhinitis, which just means drainage down the back of their throat, and local irritation, which leads to end up causing that pharyngitis or that sore throat, where it's a little red and irritated. Not to the point of strep throat infection, because that would mean it would be bacterial, but pharyngitis from that viral infection. Their upper airway secretions tend to also drain to the trachea, which can also create a cough in the common cold. And then their cervical lymph nodes might be swollen and palpable as well. Therapeutic management for the common cold or acute nasopharyngitis. There's no specific treatment available. It really is supportive and symptomatic care. We do not promote giving antibiotics, and the reason being is because most of those infections are viral. It just needs to run its course. Antibiotics are not going to speed the recovery. It's not going to help in any sense when it's a viral infection. The only time we would ever do antibiotics is if it was bacterial. And we know that by overprescribing antibiotics, it just ends up creating a lot of resistance to different things, or it makes it harder to sometimes cure some of those bacterial infections. So we want to be careful about when we actually prescribe. Well, we're not prescribing it, but when patients are getting antibiotics, that they are for the proper reason. So again, the symptomatic treatment, antipyretic for the fever, for the pain and discomfort they might be having, Tylenol or ibuprofen. Again, with ibuprofen, they have to be at least 6 months of age before they can have that. We do not do aspirin, so no aspirin for a fever. And the reason I leave that in there is because that is more of an old um, wives' tale or way to treat it, home remedy. Before we had Tylenol and ibuprofen, the most common thing they would give for a fever and for aches and pain was aspirin. And then we found out aspirin wasn't good for kids, and they developed something called Rye syndrome, or can develop something called Rye syndrome. So again, we want to make sure parents and families know no aspirin whatsoever for fever. It really should be Tylenol or ibuprofen. If the infant is having difficulty nursing because of that nasal congestion, there's some things we can tell the family to do. They can simply just do some nasal saline drops or a nasal spray to help kind of loosen that up. That'll liquefy that nasal secretion to help them drain a little bit better. They can use a bulb syringe to help clear those nasal passages. I never used it, but I've had lots of students tell me they've used a product called Nose Frida, and it kind of looks like a little straw device where you put it in the infant's nose. There's a little reservoir at the other end, and just like a straw, a parent sucks through this straw-like apparatus. There's a one-way valve, so mucus does not go in the parent's mouth, but it goes into the little trap, and it's just another version of like a bulb suction syringe. It's doing the same thing. It's just trying to get that mucus and help clear those nasal passages. What that does, regardless of how they clear those nasal passages, the idea is that it's helping get rid of that mucus, helping them to breathe a little more freely. They're able to suck more efficiently. So again, think about your infant. They're nasal breathers up to about 6 months of age. So imagine being all stuffy and you can't breathe and you can't nurse. So that's a little troublesome for them at times, making it a little more difficult. So again, trying to, especially before feedings and bedtime, would want to do the nose drops and the bulb suction to try and get some of that stuff out. We do not want to do any cough and cold preparations. Those are not generally recommended. With a cough, you don't ever want to suppress the cough. The whole point of the cough is it's trying to clear mucus and debris out of that respiratory tract. However, you got to think with infants don't have a good cough reflex, right? So again, all the more reason why we do not want to give them anything like a cough suppressant to stop that. Coughing helps to clear that. And then a cool mist vaporizer could be something else that maybe they use in their room just to help loosen up any nasal secretions. Our next disorder we're going to talk about for upper respiratory tract is pharyngitis. So pharyngitis is just infection and inflammation of the pharynx, typically manifested by a sore throat. Peak incidence is between 5 and 15 years of age, more common in winter and spring, and the incubation period is usually about 2 to 5 days. Pharyngitis can be bacterial or viral in origin, so we're going to go through both of those. First, we're going to talk about viral pharyngitis. Viral pharyngitis is obviously caused by a virus. Symptoms are pretty mild. They will have a complaint of a sore throat, fever. Fever tends to be lower grade fever, rhinorrhea, cough, and just general malaise, just not feeling well. On physical assessment, we can see that or feel that the regional lymph nodes may be enlarged. If we look at the back of their throat, we're going to see erythema present in the back of the pharynx and the palatine arch. And then there may be or there may not be exudate that appears on the tonsils, like in this picture. You can see there is some exudate there. And management-wise, really is just symptom management. Give them an oral analgesic like Tylenol or ibuprofen. We can encourage, especially school-age children, warm saline gargles. That might be soothing or beneficial with that sore throat. And really, we want to focus on maintaining adequate oral hydration. Because of that sore throat, we want to make sure they're not decreasing their oral intake and that they're taking in enough so that they don't get dehydrated. So, drinking is definitely more important than the eating. This slide is just a representation of the various tonsils that we do have. Uh, the first one being the pharyngeal tonsils, or what are often referred to as the adenoids. There's tubal tonsils, the palatine tonsils, which are the ones right in the back of your throat. So anytime you have a sore throat, if you ever go try looking in the mirror to see what they look like, those are the ones you're looking at. And then, of course, there's also the lingual tonsils. The most common tonsils that are removed are your pharyngeal or the adenoids and the palatine tonsils. So if you ever hear that somebody says their kid, or maybe you've had your child go through what's called a T&A, which is really just means tonsillectomy and adenoidectomy. So tonsillectomy, they're taking out those palatine tonsils, and adenoidectomy, they're taking out the pharyngeal or the adenoids. Streptococcalpharyngitis. For your very first blank, what do you think causes streptococcalpharyngitis? Hopefully the name gives you a big clue. It is not just, you can't just say streptococcus. It's specifically group A beta hemolytic streptococcus. That is the most common organism for streptococcal pharyngitis. So I'll say it again. Group A beta hemolytic streptococcus. When we do our assessment, when a child who we suspect or would have streptococcal pharyngitis, what we will usually see is marked erythemas behind the throat and in the palatine tonsils. Their tonsils themselves are enlarged. So again, for your next blank, tonsils are enlarged. They may have some white exudate in the tonsillar crypts, but not necessarily. Just because they don't have any white patches back there does not mean that they cannot have strep. I saw that specifically with my daughter. She's had strep a couple different times. One time she did, and one time she didn't have any sort of white patches back there. So don't use that as a complete guarantee that somebody couldn't have strep. So there may or may not be white exudate. They can have petechiae present on the palate as well. So just kind of little patches or red spots back there on their palate. Typically, the child's going to appear definitely a lot more ill. Not just, I don't feel good. They just, you can tell they don't feel well at all. What kind of fever do you think they're going to have? A high grade fever or a low grade fever? They're going to have a high fever. So for your blank, high fever. It can be as high as 104 degrees Fahrenheit. 104 degrees Fahrenheit. And that's because, think about your cause. It's bacterial cause, right? So usually with bacterial infections, you tend to have a higher grade fever. They have an extremely sore throat. It may be so sore that they refuse to want to eat or drink, or they're having more difficulty swallowing. And I've even seen some kids who refuse to swallow and they just kind of drool because they don't want to swallow their saliva even. So an extremely sore throat. They often do have difficulty swallowing. You can often see that it hurts when they swallow. They really have kind of that hard swallow because it hurts so bad. They may complain about a headache or a stomach ache as well sometimes. When it comes to diagnosing whether it is viral or bacterial, our diagnostics we're going to use most typically is just simply doing a rapid antigen test or a throat culture. So they're going to swab the back of that throat if a kid comes in complaining about a sore throat. And really what we're doing is just looking for the presence of the streptococcus bacteria. So oftentimes you'll hear it referred to as a rapid strep test, and that's exactly what they're going to do. So even when they get the rapid strep test, they're always, especially even if it comes back negative, maybe not so much positive, but if that rapid strep test comes back negative, they'll probably still send it on for a throat culture just to make sure it wasn't a false negative. And that will just confirm again that it's whether it's viral or bacterial cause. Obviously, if it's viral, I should say, it's just symptom management, no antibiotics needed. Now, therapeutic management, typically, if the rapid strep test comes back positive, so they are positive for strep throat or streptococcal pharyngitis, then we need to give them what? Do you think for 10 full days? Need to give them oral antibiotics. So for your blank, oral antibiotics for a full 10 days. Typically, unless there's an allergy, Typically what we give them is penicillin or a cephalosporin if they are allergic to penicillin. And again, really emphasizing on the need to make sure that they finish that full course of antibiotics. Don't just wait till they're feeling better, because we do know that there are complications from not completing the antibiotic course. Either the strep throat itself, they could be reinfected with it, or there are complications that we'll talk about in the GU system. One of those being called acute streptococcal or acute glomerular streptococcal infection, or in cardiac, they can have rheumatic fever is another one. So again, we want to prevent those types of things. So, and I have those complications listed right there. Besides the antibiotics and of course some other teaching, which I'm going to hit on a little bit more here in just a second, really the rest of it is just supportive care, no different than what we would do for viral pharyngitis that I've already discussed. So again, just pain management, encouraging the oral intake. When it comes to teaching side of things, again, making sure they finish that antibiotic, the full course of antibiotic. The other thing that'd be important to teach them, can't go back to school for at least 24 hours on antibiotics. So most kids bounce back pretty quick. Some they might need to stay out a little bit longer if they're still kind of feeling crummy and tired. But most, usually once they get 24 hours of antibiotics under their belt, they're usually ready to go back to school. So definitely can't go back to school or do activities until they've been on antibiotics for 24 hours. And the other thing to teach too is they need to replace their toothbrush. So reason being is if they're brushing their teeth, doesn't matter, you finish that whole course of the 10-day antibiotics. If you haven't replaced that toothbrush, guess what? The bacteria are in that toothbrush. As soon as they're done, they keep using that same toothbrush, they can just end up basically reinfecting themselves. So best thing to do, actually replace it a couple different times. Once they've been on the antibiotic for 24 hours, switch it out. Just go get a cheap one. And then if they don't do it, then definitely, or the second time they're going to switch it out, when they've completed that full course of antibiotics, they need to switch out that toothbrush. Really important to tell family to do that. Okay, next, we're going to talk about tonsillectomies. And the reason we typically do tonsillectomies is, guess what? Because they've had so many strep infections, that streptococcalpharyngitis, oftentimes. Or again, maybe there's reasons that that's causing problems with the airway obstruction. So tonsillectomy is just simply we're taking out the palatine tonsils for your blank, the palatine tonsils. Again, most frequently because of those frequent throat infections, or again, that tonsillar tissue is becoming hypertrophied or really enlarged, and it's actually causing breathing problems. And then adenoidectomy is included in this as well. The adenoidectomy just means we're taking out the pharyngeal tonsils. And usually that's because it's causing an obstruction and causing sleep apnea. So those are the kids before they get taken out who are snorers, because it's causing such an obstruction. Typically removed by ligation or laser surgery. That does increase the chance of hemorrhage as well. So when we talk about post-op care for a tonsillectomy, immediate post-op period, when we talk about positioning, we want to place them in a position to facilitate any sort of drainage if they would bleed, or just, their mucus and saliva, because maybe they're not fully awake and aren't swallowing, or their swallowing capability is certainly decreased. So we want to make sure that we're usually putting them side-lying in the immediate post-op period just to help facilitate that drainage. And then once they are fully awake, we can elevate their head of the bed. And usually, in my experience, most times the physician will actually write, especially if they're staying in the hospital overnight, they will actually write to encourage head of bed at 30 degrees or more. One of the big things we want to think about and observe for or assess for are signs of bleeding. So for kids, think about it. If you've got a toddler, they're not going to tell you that they taste blood in the back of their mouth or they feel like something trickling down the back of their throat. That's going to be an older kid who can tell you those things. So we look for some other signs. One of the big ones is frequent swallowing. So for your blank, frequent swallowing. Or are they constantly clearing their throat? Excuse me. Throat clearing. And that's often, again, because if they've had a lot of drainage, they feel that need to try and clear their throat. If they're just kind of restless and anxious, that might be another sign. Certainly a big one, bright red emesis. That's an obvious sign for bleeding. If they have tachycardia and pallor, those might be a little bit later signs. That tells you probably a little more blood loss. And the biggest risk and time frame for bleeding would be within the first 24 hours post-op. So first 24 hours post-op, and then again at days 5 to 7 after surgery. So first 24 hours post-op and days 5 to 7 after surgery are their greatest risk for bleeding. So within the first 24 hours, kind of an obvious reason for risk. It's just that it's a fresh and new surgery, greatest chance for hemorrhage there. And then why do you think for days 5 to 7 post-op? I don't know if any of you have ever been through a tonsillectomy, either for yourself or with kids. So the reason 5 to 7 days post-op, that's because that's when that scab that essentially forms in the back can slough off. And then if that sloughs off, or it sloughs off too early especially, certainly things haven't healed all the way, and it would just open that up, and that, again, that chance for hemorrhage. If you have never seen a tonsil bleed, it is impressive. It's a very vascular area, so bleeding, especially if it's a large area that's open, bleeding can occur very quickly, and a large amount of blood loss can happen rather quickly as well. Some other post-op considerations to think of, you always want to assess airway. That should be a given, so thinking about your ABCs, so airway and vital signs. You want to monitor for any sort of difficulty breathing related to oral secretions, edema, and again, bleeding as well. The comfort measures, we can administer an analgesic that's prescribed. We usually want to do that on a regular basis, even if it is prescribed PRN. You want to keep up with that. So it just depends on the physician, if it's and the age of the child, obviously, and allergies too. So for younger kids, sometimes they just do, I've seen them do just Tylenol. I've seen just Tylenol and ibuprofen. As they get a little bit older, sometimes they can do a narcotic type like Loratab elixir or hydrocodone elixir. You don't too often see Tylenol with codeine elixir anymore because there have been some documented cases where there's been difficulty after multiple doses, and it's just building up in their system and not getting out and or being processed by the body, and then it's building up in the body and then causing problems with respiratory status. So you don't too often see T3 liquid given anymore, but you might see hydrocodone or, like I said, Loratab elixir, Tylenol, or a combination of Tylenol ibuprofen. So whatever it is, liquid analgesics are obviously a lot easier to swallow than pills. That throat is sore. The big thing too is whether they stay in the hospital or they go home with parents after a few hours. We really want to make sure parents are keeping up with pain management. It's a lot easier to stay on top of it than it is to get behind on pain and try and get them back to a comfortable place, right? Because pain management is huge, not only just for comfort, but also for hydration purposes, right? So we want to make sure they keep drinking more than eating. They can go a couple days without really eating anything. Their appetite will come back. But we want to make sure they're keeping up with oral hydration so that they don't get dehydrated. And if they would get dehydrated, they're at greater risk for bleeding because if those scabs slough off too early, again, that opens it up and then we have a risk for hemorrhage. So again, pain management is important. Ice collar can be beneficial. Some kids like that, some don't. It's just simply an ice pack that they put on the outside of their neck or can hold on the outside of their neck for comfort. Offering ice chips and sips of water just to help kind of keep that throat moist so it doesn't dry out and that doesn't create more pain is another thing that can be done. When it comes to their diet, we want to start out encouraging clear liquids and fluids after the return of the gag reflex. So basically meaning they've got to be fully awake enough. We don't want to give them something too soon if that gag reflex hasn't returned because then we can have a risk for aspiration. We want to avoid acidic and citric juices. So don't give them orange juice. That will burn like no other. So that's not the best choice. Probably lemonade's not a good choice either. And you also want to avoid milk-based products. And that's because milk and ice cream and puddings, even though those are all the things kids love, actually can increase the thickness of their secretions, which again can make them want to clear their throat or make it feel like there's something stuck back there. So we usually try and tell them to avoid milk-based products. However, if that's all the kid really wants and that's what they're going to eat or drink, then by all means give it to them. It's better than nothing at all. We also encourage them to avoid red fluids, so red popsicles, fruit punch, red foods, and that's the reason being is if they would vomit, those items can often be mistaken for swallowed blood. So for swallowed blood. After about 24, 48 hours, they can advance their diet to soft foods and really the things that they're, whatever's easiest and more comfortable. We usually try and stick to softer foods. It's a little easier on the sore throat for keeping up with their diet. Again, drinking is most important. When it comes to teaching and instruction for the child and the family, we really want to discourage them from coughing and throat clearing and blowing their nose because that puts them at increased risk again for hemorrhage. We want to avoid straws. It depends on the physician you go to. I've seen some physicians say no straws. I've also been at Riley where they didn't care if the kid has straw. And I really think that has to do with, again, what type of procedure did they do? How did they cauterize things back there? So in some cases, they don't want them doing straws. That's kind of the old school method because they didn't want to disrupt essentially that clot that's back there. So if you've ever had wisdom teeth, same kind of idea. You don't want to disrupt that and create bigger issues where that could come off and then again, bleeding occurs. And then, of course, we'll teach them about manifestations of hemorrhage, what to look for. Same thing with manifestations or signs and symptoms of dehydration. Making sure, again, their child tries to stay up on staying well hydrated. And if they're not, again, what are those signs and symptoms of dehydration to look for so they know when to seek care? And signs and symptoms of infection would be important as well to teach the parents to know when to notify the provider. Continuing on with our upper respiratory illnesses, we're going to move into croup syndromes. So for croup syndromes, it can involve the epiglottis, the glottis, and the larynx. Croup syndromes are characterized by some classic symptoms, and usually those are hoarseness, a barking cough or seal-like cough, inspiratory stridor, rales and rhonchi on auscultation, and there are varying degrees of respiratory distress. So we have 5 croup syndromes that we're going to talk about in no particular order. Epiglottitis, laryngitis, spasmodic laryngitis, laryngeotracheal bronchitis, or often referred to as LTB, and tracheitis. For those of you who are writer type learners or like to rewrite information or really like that compare and the contrast, if you go to pages on Ivy Learn and you go under the Peds Lecture Resources 2 page there and then once you're in that page and then you go under, I think it says helpful, not case studies, it's helpful study aids or study aids. There is a croup syndrome grid for all 5 of these croup syndromes that you can compare and contrast signs and symptoms, treatment, nursing care, all of that. You can do those if you're that person who's like a visual and a writer. That might help you to compare and contrast some of these croup syndromes because there's a few that are really going to sound super similar, and I'm going to try and point out the things that make it or set them apart. Our first croup syndrome we're going to talk about is acute laryngitis. This is probably the easiest one of all the croup syndromes, but acute laryngitis is just simply inflammation of the larynx, for your blank, the larynx. It results in a brassy, hoarse voice sound, or sometimes even the inability to make an audible voice sound. So if you've ever been to maybe a sporting event or a concert where you did a whole lot of screaming and then hours later or the next day you have a really brassy, hoarse sounding voice, or maybe you can't talk at all, that's an example of acute laryngitis. Or sometimes just when you get a really bad cold Again, this can be a complication of like pharyngitis. Um, again, the excessive use of the voice that I already used. Those are cases of acute laryngitis. Our treatment for it, it's really just symptomatic treatment and giving it some time. So sips of fluids, whatever feels more comfortable, is more soothing to the child. It could be warm liquids, it could be cold liquids, whatever they prefer. And then really we want them to rest their voice for at least 24 hours. So trying to minimize how much they're talking or trying to use their voice. So for an infant, the way we try and get them to rest their voice is just simply trying to meet their demands or their needs, I should say, before they cry. So trying to anticipate when they might be hungry or that they need to be changed or maybe just kind of held for a little bit to really try and minimize them crying. And for an older child, especially one who can, um, write, you could provide a paper and pencil or like a whiteboard, cell phone. Just be careful if you do a cell phone. They might be texting you or friends all day long, right? So just another way to try and communicate with them so they're not having to use and strain their voice even more. Our next croup syndrome we're going to talk about is called acute LTB, or that which is the short name for it, but LTB stands for laryngeotracheal bronchitis. So it is inflammation of the larynx, trachea, and the major bronchi. So for your blanks, the inflammation of the larynx, trachea, and major bronchi. It affects ages 6 months to 3 years of age. So I know the picture on your slide is a little bit different. If this is just one of those little pictograms, sometimes that's helpful. But what I want you to know is it affects ages 6 months to 3 years of age. It is usually viral, for your next blank, usually viral. So parainfluenza is the most common virus that we see with that. Assessment-wise, these kids, they go to bed with very minimal symptoms at bedtime. They might have a temperature that is normal or even low grade, nothing significant. Probably just make you think, oh, they've got a little bit of a common cold starting. They'll develop a barking cough, that croup-like or seal-like barking cough, inspiratory stridor, and they can have marked retractions as well. Not all kids will have marked retractions, so they may not. Again, it just depends on how severe it's affecting them and causing respiratory distress. But what is unique about acute LTB is it pretty much only occurs at night. So they go to bed with these minimal symptoms, not really have any problems. What will happen is they'll wake up in the middle of the night with all of these symptoms much more pronounced. These symptoms will last for several hours and then they subside by morning. So again, they may or may not wake up in the middle of the night and they have, again, this barking cough, this inspiratory stridor. They sound horrible. And especially the more respiratory distress it's causing, they're going to be more restless, maybe have those retractions. And again, this can last for several hours during the night, but then by morning, it's like nothing happened. They're fine, they're normal, they don't have the distress, they're not having any stridor, they're not having that barking cough. They're like their normal kid. So symptoms last for several hours, then subside by morning. Again, in the infant and toddler, we can also see some nasal flaring, the intercostal retractions, and they may have tachypnea and continuous stridor. So again, these are all signs and symptoms of increased respiratory distress that we can see. Again, the other thing that's unique about LTB is this can occur for several nights in a row. So this doesn't usually just occur for one night. It's usually several nights, and then it'll disappear once that virus illness has run its course. When it comes to therapeutic management for acute LTB, for the most part, most cases, this can be treated and managed at home. So just doing a little bit of education with parents about what they can do. As long as the child is not getting into severe respiratory distress and they're not worsening or they're tiring out, then this can be managed at home in most cases. So the best thing we tell parents to do is actually just take them into a bathroom, shut the door, turn on hot water, and create that steam in the bathroom and just sit. Just sit on the floor, sit on the toilet with your child or with the child and just let them breathe in that nice warm steamy air. Do that for about 15 minutes. And a lot of times that will actually ease their respiratory um, distress that they're having. You'll see a little bit less of the stridor or hear a little bit less of the stridor. The retractions, if they were having them, should hopefully lessen, and that barking cough kind of seems to calm down and soothe. If for some reason during that time they're in there it does not improve and they seem like they're working harder, their respiratory effort is getting more difficult, then it would be important to send them on to a healthcare facility like the ER to get treatment. So if they are going on or do go or show up to a healthcare facility, then the things we would want to do in a healthcare facility would be to monitor their continuous oximetry. So put a pulse ox on them, see what their O2 sat is. If need be, we can give them some supplemental oxygen as needed just to make sure we keep their sats up. Typically with peds, we just like adults, we typically like to see their sats above 90%. Some physicians will even write above 92%. So just kind of is a preference, but a general rule is usually above at least 90%. We can also give them in the hospital a cool mist with corticosteroids. Why do you think we would want to give them corticosteroids? So go back and think about what's happening in their airway, upper airway, what's causing inspiratory stridor. So that's usually related to there's some swelling. So just again, because of that virus and sometimes in the distress that they get in and what's causing the inspiratory stridor is because they've got swelling in that upper airway that's creating that. So sometimes what we can give them, the corticosteroid we usually give them is dexamethasone. So again, a steroid that's going to help reduce that swelling. I will say, even when you give the dexamethasone, that is not something that works necessarily quickly. For it to get peak effect is about 6 hours. So that is something we'll give them. It's going to help open up the airway because it's reducing the swelling, but it takes a while for that drug to really take effect and have a good effect on the inflammation that's occurring. What we can give them more quickly to help vasoconstrict and decrease any subglottic edema is actually racemic epinephrine, and we would give that via a nebulized treatment. So it's just an aerosolized nebulized treatment that they would give them. It's called racemic epinephrine. That is going to work much quicker. So it has a quicker peak effect. However, it doesn't last as long. So a lot of times what we'll do is give them a racemic epinephrine, again, that causes mucosal vasoconstriction, and it decreases that subglottic edema. And a lot of times what they'll do is they'll give them the racemic epinephrine first, and then either right behind it or kind of at the same time, they'll give them the dexamethasone through an IV. So the racemic epinephrine is going to work a lot quicker. However, it's only going to last probably about 2 to 3 hours before it starts to really kind of wear off and the kid's starting to get back into the same symptoms if we don't do something else. And that's where the dexamethasone, when you give that right behind the racemic epinephrine or at the same time, racemic epinephrine is kind of going to get them through that first few hours. And then as it's starting to wear off, guess what's starting to take effect and start working? And that would be the dexamethasone to help reduce that swelling even further. In some cases, if they're really in a lot of respiratory distress and working really hard to breathe or breathing really fast, think about it, you're losing fluids that way, and they're too tired to keep up with drinking, they don't feel well. So in some cases, if they're going to be admitted or watched for a while, they may need to put an IV in and then give them IV therapy just to make sure they still stay well hydrated. And if that's the case, and even if they don't have an IV, you still want to do good isonos just to make sure that they're not getting dehydrated. And if you're going, well, I don't understand where dehydration comes in with this. I thought it was a problem with airway. Well, with kids, naturally they have, without any issues, breathe a little bit faster than the adults. So if you think back to our growth and development chapters and talking about respiratory rates through the different age groups, definitely a faster breather in general. And whenever there's an illness and they're working harder to breathe and they're working faster because of respiratory compromise, then that's another way that they're losing fluids. So it's important to make sure that we're staying up with hydration as well. When it comes to therapeutic management for acute LTB, for the most part, most cases, this can be treated and managed at home. So just doing a little bit of education with parents about what they can do. As long as the child is not getting into severe respiratory distress and they're not worsening or they're tiring out, then this can be managed at home in most cases. So, the best thing we tell parents to do is actually just take them into a bathroom, shut the door, turn on hot water, and create that steam in the bathroom and just sit. Just sit on the floor, sit on the toilet with your child or with the child, and just let them breathe in that nice, warm, steamy air. Do that for about 15 minutes. And a lot of times that will actually ease their respiratory um, distress that they're having. You'll see a little bit less of the stridor or hear a little bit less of the stridor. The retractions, if they were having them, should hopefully lessen, and that barking cough kind of seems to calm down and soothe. If for some reason during that time they're in there it does not improve and they seem like they're working harder, their respiratory effort is getting more difficult, then it would be important to send them on to a healthcare facility like the ER to get treatment. So if they are going on or do go or show up to a healthcare facility, then the things we would want to do in a healthcare facility would be to monitor their continuous oximetry. So put a pulse ox on them, see what their O2 stat is. If need be, we can give them some supplemental oxygen as needed just to make sure we keep their sats up. Typically with peds, we just like adults, we typically like to see their sats above 90%. Some physicians will even write above 92%. So just kind of is a preference, but a general rule is usually above at least 90%. We can also give them in the hospital a cool mist with corticosteroids. Why do you think we would want to give them corticosteroids? So go back and think about what's happening in their airway, upper airway, what's causing inspiratory stridor. So that's usually related to there's some swelling. So just again, because of that virus and sometimes in the distress that they get in, and what's causing the inspiratory stridor is because they've got swelling in that upper airway that's creating that. So sometimes what we can give them, the corticosteroid we usually give them is dexamethasone. So again, a steroid that's going to help reduce that swelling. I will say, even when you give the dexamethasone, that is not something that works necessarily quickly. For it to get peak effect is about 6 hours. So that is something we'll give them. It's going to help open up the airway because it's reducing the swelling, but it takes a while for that drug to really take effect and have a good effect on the inflammation that's occurring. What we can give them more quickly to help vasoconstrict and decrease any subglottic edema is actually racemic epinephrine, and we would give that via a nebulized treatment. So it's just an aerosolized nebulized treatment that they would give them. It's called racemic epinephrine. That is going to work much quicker. So it has a quicker peak effect. However, it doesn't last as long. So a lot of times what we'll do is give them a racemic epinephrine, again, that causes mucosal vasoconstriction, and it decreases that subglottic edema. And a lot of times what they'll do is they'll give them the racemic epinephrine first, and then either right behind it or kind of at the same time, they'll give them the dexamethasone through an IV. So the racemic epinephrine is going to work a lot quicker. However, it's only going to last probably about 2 to 3 hours before it starts to really kind of wear off and the kid's starting to get back into the same symptoms if we don't do something else. And that's where the dexamethasone, when you give that right behind the racemic epinephrine or at the same time, racemic epinephrine is kind of going to get them through that first few hours. And then as it's starting to wear off, guess what's starting to take effect and start working? And that would be the dexamethasone to help reduce that swelling even further. In some cases, if they're really in a lot of respiratory distress and working really hard to breathe or breathing really fast, think about it, you're losing fluids that way, and they're too tired to keep up with drinking, they don't feel well. So in some cases, if they're going to be admitted or watched for a while, they may need to put an IV in and then give them IV therapy just to make sure they still stay well hydrated. And if that's the case, and even if they don't have an IV, you still want to do good isonos just to make sure that they're not getting dehydrated. And if you're going, well, I don't understand where dehydration comes in with this. I thought it was a problem with airway. Well, with kids, naturally they have, without any issues, breathe a little bit faster than the adults. So if you think back to our growth and development chapters and talking about respiratory rates through the different age groups, definitely a faster breather in general. And whenever there's an illness and they're working harder to breathe and they're working faster because of respiratory compromise, then that's another way that they're losing fluids. So it's important to make sure that we're staying up with hydration as well. Our third croup syndrome we're going to talk about is acute spasmodic laryngitis, also referred to oftentimes as spasmodic croup or midnight croup. This one is a self-limiting illness that can actually result from allergens. So more commonly from allergens versus a virus. It's characterized by what they call perioxysmal attacks of the laryngeal obstruction. Again, these mainly occur at night. So very similar to what we just talked about with LTB. It occurs at night. Assessment-wise, they have that croupy, barky cough. They're restless. Again, it's happening at night, so they're having these nighttime episodes of laryngeal obstruction, which is resulting in difficulty breathing and hoarseness. So again, sounds very similar to LTB. One thing that will set it apart as well, besides that it's result primarily of allergens, is the age group it affects. It affects ages 1 to 3 years, so slightly different than your LTB. When we talk about therapeutic management, because this is pretty self-limiting, it just kind of has to run its course. The best thing, even though it's caused by an allergen, it can still cause respiratory distress for these kids. So again, these kids go to bed fine, and then overnight or during the night, they develop these perioxysmal attacks because it's causing laryngeal obstruction, getting them into respiratory distress a little bit. Varies per child, but the best thing we actually tell them to do is have for home management is just sudden exposure to cold air. So take these kids out into the cold night air, let them breathe in that cooler air. That'll help reduce the laryngeal obstruction that's occurring, as well as slow those perioxysmal attacks of the laryngeal obstruction. So this time instead of LTB, we took them into the bathroom, this time with spasmodic laryngitis or midnight croup. We're going to take them out into the cold night air. Say it's not real cold out, well, then go open up the freezer door and stick their head in the freezer. Don't shut it on them, but go stick their head in the freezer and let them breathe in, or just stand in front of that freezer and let them breathe in that cool air. That will help relax that airway. In case that their symptoms get worse or it's just not improving, again, they can go onto a healthcare facility for further treatment. And typically what they'll do is they may hospitalize them or observe them for a few hours. They'll give them the cool mist humidity again, or racemic epinephrine via nebulizer treatment, just like with the LTB, and they can give them corticosteroids to help with that laryngeal obstruction. Our third croup syndrome we're going to talk about is acute spasmodic laryngitis, also referred to oftentimes as spasmodic croup or midnight croup. This one is a self-limiting illness that can actually result from allergens. So more commonly from allergens versus a virus. It's characterized by what they call perioxysmal attacks of the laryngeal obstruction. Again, these mainly occur at night. So very similar to what we just talked about with LTB. It occurs at night. Assessment-wise, they have that croupy, barky cough. They're restless. Again, it's happening at night, so they're having these nighttime episodes of laryngeal obstruction, which is resulting in difficulty breathing and hoarseness. So again, sounds very similar to LTB. One thing that will set it apart as well, besides that it's result primarily of allergens, is the age group it affects. It affects ages 1 to 3 years, so slightly different than your LTB. When we talk about therapeutic management, because this is pretty self-limiting, it just kind of has to run its course. The best thing, even though it's caused by an allergen, it can still cause respiratory distress for these kids. So again, these kids go to bed fine, and then overnight or during the night, they develop these perioxysmal attacks because it's causing laryngeal obstruction, getting them into respiratory distress a little bit. Varies per child, but the best thing we actually tell them to do is have for home management is just sudden exposure to cold air. So take these kids out into the cold night air, let them breathe in that cooler air. That'll help reduce the laryngeal obstruction that's occurring, as well as slow those perioxysmal attacks of the laryngeal obstruction. So this time instead of LTB, we took them into the bathroom, this time with spasmodic laryngitis or midnight croup. We're going to take them out into the cold night air. Say it's not real cold out, well, then go open up the freezer door and stick their head in the freezer. don't shut it on them, but go stick their head in the freezer and let them breathe in, or just stand in front of that freezer and let them breathe in that cool air. That will help relax that airway. In case that their symptoms get worse or it's just not improving, again, they can go onto a healthcare facility for further treatment. And typically, what they'll do is they may hospitalize them or observe them for a few hours. They'll give them the cool mist humidity again, or racemic epinephrine via nebulizer treatment, just like with the LTB, and they can give them corticosteroids to help with that laryngeal obstruction. Right. Our fourth croup syndrome we're going to talk about is acute epiglottitis, and that just means there's inflammation of the epiglottis, which the epiglottis is that little flap of cartilage that covers the opening of the larynx to keep food and fluid out during swallowing. So this is considered, if they would have acute epiglottitis, it is considered a medical emergency because it can lead to airway obstruction. So for your blank, can lead to airway obstruction. It is most frequently seen in children 2 to 8 years of age. And our most common cause, H. influenza type B, or think of HIB, H-I-B, HIB. H. influenza type B is the most common. Do you think it's viral or bacterial cause? So you got to think about what is HIB, what is H. influenza type B. That is actually a bacterial cause. So bacterial cause for your blank. Assessment-wise, it usually will begin as just a mild upper respiratory tract infection. So upper respiratory infection, and then after 1 to 2 days, inflammation spreads to the epiglottis, and then they're going to suddenly develop severe inspiratory stridor. What kind of fever do you think they're going to have if it's a bacterial cause? They're going to have a high fever, right? So bacterial cause, high fever. They can have hoarseness and a very sore throat. So sore to the point where they don't want to swallow. They're not wanting to eat or drink because it hurts too bad. Oftentimes you'll also see drooling, and they'll also tend to sit in what's called the tripod position. And they insist that what we call the tripod position is when they insist on sitting up, leaning forward with their chin thrusted out, mouth open, and their tongue protruding. Because guess what? What's happening to their airway? It's starting to close off. It's becoming obstructed. So they're really just trying to get air and be able to breathe however possible. They often will refuse to try and lay down. Like if you try to lay them back, they don't want to because they feel like they can't breathe. If you try to stimulate the gag reflex, the epiglottis is actually seen as a cherry red structure, which is what you can see in the second picture. That's actually an intubation blade that you're seeing, but the structure above it would be that cherry red epiglottis. The problem is when you do try and do a gag reflex or stimulate that, that can actually create a complete obstruction of the epiglottis. So you never, ever, ever, if a kid would come into a doctor's office or the ER, if you're working there, you never want to attempt to visualize the epiglottis directly with a tongue blade or obtain a throat culture in this case. So you're looking for all those other signs and symptoms, and if you're suspecting potentially acute epiglottitis, never attempt to visualize the epiglottis or get a throat culture because you're worried that you could ultimately occlude their airway. And then we got bigger issues, right? So unless you basically are ready to provide an artificial airway immediately, like through a tracheostomy or an ET tube, we're not going to do those things. The throat should only be visualized by the physician with emergency equipment ready. Right, our therapeutic management for acute epiglottitis. If they are having cyanosis or respiratory distress is present, we want to give them oxygen because, again, as that airway is becoming more occluded, poor oxygen exchange, so give them some supplemental O2. They're going to need IV fluids, which obviously means they're going to need an IV for several different reasons, not just for IV fluids, but also for the medications that we're going to give them. They're going to get antibiotics. Why do you think they're going to get antibiotics? Go back to what's our cause. It's a bacterial cause, so we need to treat that infection, right? So antibiotics, we're going to give them corticosteroids. What are our corticosteroids going to do for them? It's going to help reduce that inflammation that's occurring. And most commonly, because we are so worried about their airway and it becoming occluded, oftentimes we do need to establish an ET airway, so endotracheal intubation, to make sure that we're protecting and we have a well-established airway. Again, that would be something you'd want to have close by so that you're not looking for it if things change for them rapidly. Your nursing care, we want to, again, protect that airway. So for your blank, protect that airway. Even before we get intubation, we would want to protect that airway. You want to avoid throat cultures or using a tongue blade, again, because we said that could create a total obstruction. Be prepared or prepare for intubation. We want to provide humidified oxygen, monitor their continuous oximetry or pulse ox. Again, administer corticosteroids and IV fluids and antibiotics as prescribed. And they do need to be in droplet precautions for the first 24 hours after antibiotics are initiated. Now, we all know in the hospital setting, usually once you go into isolation precautions, you don't really come out until you're discharged, but minimally they need to be in droplet isolation. Why do they have to be in droplet? Go back again to your cause. H. influenza type B. What are they doing? They're coughing, they're sneezing, well, maybe not really sneezing, but they're coughing. Those droplets from those can be spread. So they need to be in droplet isolation at least for 24 hours after the IV antibiotics have been started. And the other thing, even though I don't have it in your notes, think about that child and that family. If the child has bacterial cause or acute epiglottitis, that family has already probably been exposed. So oftentimes what they will do is even put the family on prophylactic antibiotics, or anyone who's been in close contact with the child who has acute epiglottitis. They'll give them prophylactic antibiotics because they've already been exposed to that bacteria. And the other thing that we do for prevention of this, again, it's not a guarantee, but go back and think about your immunizations that they get. Typically, what we give is the Hib vaccine. Again, that's trying to protect against H. influenza type B. All right, our last croup syndrome we're going to talk about is bacterial tracheitis. It is considered a medical emergency. It can actually be a complication of LTB, or acute laryngeotracheal bronchitis. It is an infection of the mucosa of the upper trachea. So for your blanks, I'll repeat that. Infection of the mucosa of the upper trachea. It's usually Staphylococcus aureus or Hib. It is seen in 1 month to 6 years of age, typically. It can be serious enough that it causes airway obstruction, serious enough that it actually can result in respiratory arrest. So again, that's why it's considered a medical emergency. The clinical manifestations. The clinical manifestations are going to mimic just like LTB, but it does not respond to LTB treatment. So again, all those same things that we talked about with LTB, we're going to see again with this. The problem is that medical management that we do for LTB, the child does not actually respond to that treatment. Well, when we get investigating and asking questions, they also usually have a history of previous respiratory infections and a croupy cough. Their stridor that's present is usually unaffected by the position, meaning it doesn't matter if they're laying down, sitting up, they have stridor no matter how they are positioned. They often have a toxic appearance with a high fever. So again, think about what's our cause. It goes back to the Staphylococcus aureus or Hib, which is a bacterial cause. So we tend to have a higher fever. When I say they have a toxic appearance, they just look really sick. They look ill. You can tell they obviously don't feel well. Just not good, right? They're not very active, and just kind of pitiful looking, actually, because they're just so sick. And they also have very thick, purulent secretions that can also result in respiratory distress because they have a copious amount and how thick they are. And again, thinking about your age group, 1 month to 6 years, especially the infant and toddler, they're not good at being able to clear that cough and that mucus. So then it can end up creating more respiratory distress, and it can actually even cause respiratory arrest. Our therapeutic management and nursing care for bacterial tracheitis is, again, we want to protect that airway from the beginning. So again, position them whatever is more comfortable, making sure we're doing a good respiratory assessment, and part of protecting that airway, we're doing vigorous care of the airway, so frequent suctioning. They may even require an ET or a trach to make sure we have an adequate airway for them. Humidified oxygen is probably going to be needed, as well as antipyretics for the fever and antibiotics for the infection itself are all important things we would need to be doing. On this slide is just a couple videos. The first one, the croup with severe stridor. If you click on that link, it's just a short little video just to kind of show you an example of what croup looks like with severe stridor that you can hear. And then also that the young IV croup one is just a fun video to watch about croup. Again, just something to make it stick in your mind exactly what croup is, what it may look like. Okay, now we're going to start talking about disorders of the lower respiratory tract. And the first one we're going to discuss is bronchitis. So bronchitis is just simply inflammation of the major bronchi and trachea. Major bronchi and trachea. It is more common in preschool and school-age children. And there's several different causative agents. There's a few listed there: influenza virus, adenovirus, and the M. pneumonia are just a few. Assessment-wise, a child will usually develop mild upper respiratory infection. That's what URI is, upper respiratory infection, for about 1 to 2 days. And then they will develop a fever, for your blank, a dry hacking cough, which actually can become hoarse and mildly productive, enough so that it is serious enough to wake the child from sleep. Those symptoms can last for a week, and full recovery can actually take as long as 2 weeks. They can also have rhonchi and coarse crackles on auscultation. Diagnostic, we can do a chest x-ray, and that'll usually reveal the diffuse alveolar hyperinflation. And then therapeutic management is really just symptomatic treatment, letting it run its course, because again, these are viruses that cause this. So just simply reducing the fever if they're running a fever, again, tends to be more low grade fever. Make sure we're maintaining adequate hydration, because again, if we've got increased work of breathing with faster respiratory rate, again, that's another way we're losing fluids. Same thing as fever. It's another way that we're losing fluids from the body. So again, just maintaining adequate hydration. And then the only reason we would do antibiotics is if there was a bacterial infection present. Next disorder that we talk about is bronchiolitis. So bronchiolitis is inflammation of the fine bronchioles and the small bronchi. So inflammation of the fine bronchioles and small bronchi. More common in winter and spring. It is usually viral, and the most common causative agent that we see for bronchiolitis, for your blank, is RSV, which actually stands for respiratory syncytial virus. So RSV is for short. So that's our most common and causative agent. And it's most common for LRI, which is lower respiratory tract infection or lower respiratory infection, in children younger than 2 years of age. So you typically don't see this beyond 2 years of age, maybe a little bit in a 3-year-old, but for the most part, it's for infants and up to age 2. The peak incidence being 6 months of age. Again, the most common cause or reason for hospitalization in infancy is bronchiolitis. So what happens when there's bronchiolitis is the bronchial mucosa actually swell and the lumen will fill with mucus and exudate. When it fills with mucus and exudate, think about when it goes to your assessment, what kind of things do you think you're going to see with the respiratory system? Again, think about if this is happening under the age of 2, what's happening with that respiratory tract? Think about how small it is. How does that interfere with our gas exchange? Because that's going to explain a lot of your signs and symptoms that are going to come about for the infant with RSV or bronchiolitis. So bronchiolitis, again, most common is caused by RSV. However, you can also have bronchiolitis and it not be due to an RSV. It could be due to some other virus. But it triggers the same kind of symptoms. But again, most common cause is RSV. So a lot of times you'll hear people use bronchiolitis and RSV interchangeably, but also understand that it is not 100% always going to be caused by RSV. So assessment-wise, usually the infant kind of develops these general symptoms of a viral respiratory infection. They have some congestion, they have runny nose, the rhinorrhea, fever tends to be more of a low-grade fever. Then what happens is it progresses to that lower respiratory tract. Then you're going to see those lower respiratory symptoms. That's where they're going to develop a cough. They tend to have wheezing, retractions occurring, which retractions, again, remember, just tell you they're working harder to breathe, right? Not as good as air exchange, all because of all that mucus and exudate that's filling those lumens. They have variable presentation of respiratory distress. Some are just mild, it could be more moderate, or it could even be severe respiratory distress. Every child is really different. The way we diagnose this is that we'll do a nasal culture or nasal swab to identify the organism. Oftentimes what you'll see them do is actually do like a rapid nasal swab to see if it tests positive for RSV, but they will also then send that swab off to be cultured to confirm that it truly is RSV or that they didn't just get a false negative. So for your blank under diagnosis, they need a nasal culture to identify the organism. They typically will also do a chest x-ray, and that will actually reveal pulmonary infiltrates. So in the next slide, I will show you an example of pulmonary infiltrates. You'll see little white streaks. And backing up on the assessment piece too, what I didn't have listed in here is, yeah, they have variable presentation of respiratory distress, but their respiratory rate itself is typically going to be a lot faster and higher than what we would expect for an infant or toddler. And again, their effort, their rate that they're breathing is definitely a lot harder in the sense of their respiratory effort, which is why you see retractions. You can see sometimes some nasal flaring if it's an infant. And again, with the respiratory rate being much higher, we're also blowing off essentially or losing fluids that way because their respiratory rate is so high. It can be anywhere in the 40s to 60s because they're breathing so fast and working so hard to breathe. So again, just varying degrees. And I will talk about therapeutic in just a couple slides. All right, in this slide and in this picture that I have of the x-ray, if you see where those arrows are kind of pointing, how it looks like there's kind of like some white streaking through there, that's how they actually, when they look at an x-ray, that's what they're looking for to confirm that it's just a viral bronchiolitis, whether it be caused by RSV or something else. We're looking for kind of that little white streakiness through there. And those are those little pulmonary infiltrates that we can see. For the therapeutic management for bronchiolitis, as long as they're less severe symptoms and they're not having a lot of respiratory distress, they can actually be managed at home in a lot of cases, and that might be kind of the best place for them. Just simply for the fever that they're having, we can give antipyretics, Tylenol or ibuprofen. Again, as long as for the ibuprofen, they are over at least 6 months or older age. And we really focus on adequate hydration, making sure that they're taking in enough fluids to stay hydrated and they're not getting dehydrated. And then the other side of it, because of all that mucus causing a lot of congestion and filling up, the mucus is filling up all the lumens and making it harder to breathe, we also focus on trying to loosen up those nasal secretions and doing nasal suctioning to try and get rid of that some of that congestion anyway. So we can just promote nasal suctioning at home, just again, a bulb suction syringe. Doesn't have to be anything fancy, just trying to get some of that mucus out of there, clear up some of their airways to be able to help them to breathe a little bit easier so they're not getting into such distress. And again, before we suction them, we can do some nasal saline to help loosen that up, thin it out to help get it out of there. Also want to make sure that they are avoiding or there is avoidance of tobacco smoke, that secondhand tobacco smoke, because that is going to be more irritating to their respiratory tract and airways in general when they're already irritated with all that mucus and exudate. So we don't want to add to their problems by creating more irritation. And then they can also be just simply, again, being home monitored. That doesn't necessarily mean that they need to be on any specific monitor, just that they are monitored at home to make sure their respiratory distress is not getting worse. And if it is, when to seek proper medical attention, and whether that's going to the emergency room or, going and seeing their physician. If they're really getting into severe respiratory distress, then they need to be going on and going to an ER. So that leads me right into the next part of this for therapeutic management. Most times, if they do require hospitalization, that is because they are having, for your blank, severe distress. So hospitalization required in severe distress. And what's considered severe distress is if they are having periods of apnea, they're having hypoxemia or hypoxia, which in that case, then we would want to give them humidified oxygen to help counteract that. We would also be giving them in the hospital nebulized bronchodilators to help try and open up that airway, also loosen up all that mucus and exudate. They can do that simply by doing some of those bronchodilators, as well as sometimes they can do like CPT to help, so the chest physiotherapy to help loosen that up. For your blank underneath nebulized bronchodilators, we're so concerned about their hydration status. So they can become, for your blank, dehydration because of the difficulty with feeding. They can imagine how congested they are, and if they're working hard to breathe, they're not real into wanting to eat. So again, their oral intake usually kind of dips down. So dehydration, we're worried about dehydration due to difficulty with feeding. And in some cases, if they're not able to take in enough orally, we can do adequate hydration by giving them IV fluids for a day or two. And in some cases, we don't want them to eat. I've also seen them make them NPO for a day or two until we can get their respiratory rate and effort under control. So if they're working that hard to breathe, they also don't need to be worrying about trying to take something orally. So a lot of times they'll give them IV fluids, again, for a day or two just to eliminate that need for oral feedings because of the tachypnea. Infants tire easily and they cannot finish feedings, which again leads them into the potential for dehydration. We also want to make sure we're putting them in isolation and having good hand washing, not only to protect our other patients as healthcare workers, but also to protect any family members, which they're not going to get RSV themselves because their immune system is better. However, we don't want them spreading that to someone else or others in the family. So they need to be in isolation, and they would typically just be in droplet isolation. Sometimes you'll see them, if they're worried about contact, they'll put them in droplet and contact. I've seen both. But RSV can live on inanimate objects, so surfaces, clothing, toys, for up to 24 hours. So again, that good hand washing and isolation is key in the hospital setting. When it comes to prevention of RSV, we can't do this for everyone, but we really want to do it for especially infants who are born prematurely, or if they have some other pre-existing health conditions. We can give them something called Synagis or the Pavlozumab. That's given prophylactically, like I said, to premature infants during the RSV season, so heading into winter and that spring season. Or again, if they're less than 1 year of age and they have some sort of pre-existing health condition that puts them at risk for respiratory illnesses. It's usually given as injections monthly until we get through that RSV season. It is rather expensive, so that, again, it's not something that we give to everybody. We're really giving it to the ones who are certainly more vulnerable to picking up the RSV or bronchiolitis. Our next lower respiratory tract disorder we're going to talk about, should be pretty familiar with. Shouldn't be anything too terribly new of a concept, and that's asthma. So asthma is just considered a chronic inflammatory disorder of the respiratory tract, and it is the most common chronic illness that we see. For children, it typically presents before 5 years of age. However, they don't always give it a definitive diagnosis in those early years. You will see some kids who do, but it can be difficult to make that definitive diagnosis in the early years. Often you'll hear what it's referred to as RAD, or reactive airway disease, because again, with small children, toddlers, preschoolers, they do often react to a lot of those viral illnesses. They can mimic, again, bronchiolitis for like a 2-year-old or younger, or again, just a lot of upper respiratory infections and then sometimes transmitting to lower respiratory tract. So oftentimes those viruses kind of set off respiratory distress in different ways. So oftentimes they won't call it asthma right away. They'll call it reactive airway disease and wait to see if just simply maturity and growth and maturity of the immune system, maturity of the respiratory tract and growth of that respiratory tract. A lot of times those reactive airway type disorders will just disappear on their own and they don't truly have asthma. So again, typically asthma will present before 5 years of age. Difficult again to make that definitive diagnosis in the early years because a lot of those viral illnesses are present, and similar symptoms and viral illnesses can actually trigger asthma symptoms. So severity depends on a lot of the risk factors. Certainly genetics plays a role into it, environmental exposure, and the body's immune responses as well. When it comes to the triggers for asthma, there's lots of different ones, but asthma typically follows an initiation by an allergen of some sort, which causes that hypersensitivity to a foreign substance that leads to the allergic response or reaction that we see in the bronchi. So again, this slide just shows you lots of different options. Everybody's different as to what they react to, but again, that initiation is followed by an allergen. When it comes to assessment of asthma, typically episodes will begin with a dry cough, and that leads to increased difficulty with exhaling because the bronchioles are inflamed and they fill with mucus. So then we'll often see, besides the dry cough, we can also see dyspnea and wheezing develop. Wheezing will primarily be on, what do you think, expiration or inspiration? You should be saying expiration, so wheezing primarily on expiration, and they also have a prolonged expiratory phase. So think about gas exchange and how that works. Again, we have difficulty getting gas exchange depending on how severe the asthma attack is itself, but they often get that prolonged expiratory phase. And when we look at history, we always want to get a detailed history of the development of symptoms. So, what was the child doing at the time symptoms began? Are there any known triggers for the child? What treatments has family tried at home, especially if they're a known asthmatic and they come in with having an asthma exacerbation? What has the family already tried? Right? Have they already done either an inhaler or have they tried an albuterol, like nebulizer treatment? And like when was it? What exactly was it they did, or what other medications maybe they have used, because that can determine how in the emergency room or in a physician's office or a clinic, wherever they may go to seek treatment, how that will affect what care we would give them. So it would be important to ask those questions. What have they already tried or what have they done to relieve the asthma attack itself? Once the asthma attack is over, the exacerbation is over, it's under control, it'd be important to have the parent or child describe what the home environment is like. And really, if you think about it, we're looking for what is their trigger? What is triggering the reaction? Could it be from having pets? What's the child's bedroom like? What's their outdoor play space look like? Is there a lot of vegetation that maybe is causing that allergen trigger? What's the classroom environment if they're in school? What does that look like? What type of heating is in the house? Those are all important pieces to try and figure out what was actually triggering the asthma exacerbation in the first place. And then on physical assessment, we should more than likely see, maybe not all of these things, but a lot of them. You typically will see the wheezing. You have the prolonged expiration, so harder to get that air out. We can even see in severe cases intercostal retractions. And during the asthma attack itself, the child is usually more comfortable sitting or standing rather than lying down. If you try to get them to lie back on a bed or even lie down all the way, they often feel like they can't breathe. They just kind of can't catch their breath. They often have a lot of chest tightness as well that they'll complain about. They often want to be sitting up and typically will lean forward and they'll raise their shoulders, because what this actually does is tries to give them more breathing space to allow them to breathe a little bit easier. So like I said, oftentimes they'll be kind of leaning forward and they'll have their shoulders up a little bit higher. In this slide, we're looking at a child doing a pulmonary function test, or PFT. So these pulmonary function studies are really important to give us an idea of how much that is affecting the child, and also helps us to look at the different treatment measures we're doing as to how effective they are. So again, helpful in evaluating children for asthma. We look at their vital capacity, and it typically can be low or may be low, and their expiratory rate will be abnormally long. Again, it goes back to that they have that prolonged expiratory phase, so typically more than 10 seconds. And in the next slide, I'm going to talk to you about a peak flow meter. So this is an example of a peak flow meter, or what we would use to monitor. And what we do is we usually send them home with this. This is something they can use to check their peak flow meter daily. It measures their gross changes in peak expiratory flow, so it helps to plan what the appropriate regimen looks like. So to use the peak flow meter, what the child has to do is blow out air as fast and as hard as possible. We usually have them repeat it 2 times, and we want to record the highest number achieved as the result for that day. So then they're assigned what we call zones. There's red, yellow, or I shouldn't say red. Red is one of them. I'm going backwards. I should say green, yellow, and red zones. So each zone is associated with treatment recommendations. So typically, if you're green zone, that means keep doing like your daily medications, your PRNs as needed, and just keep maintaining that asthma is under control. If we're getting into yellow, it's kind of like, hey, the caution, you might need to do an extra med or two, or do some extra things, that we're moving in the direction of potentially an asthma exacerbation, where red zone would tell you they are definitely having an asthma exacerbation. And again, there's maybe certain meds. Every child's plan looks different, but oftentimes it will help them kind of gear when they need to do either some extra medications or seek extra care like emergency care. So there's different options for inhaler use and different guidelines about when to call the physician or seek emergency care. When we talk about diagnosis and management of asthma, it can involve several different things. One of those being we want to measure our asthma assessment and monitoring. So that can involve looking at the history and physical exam, and certainly objective testing as well to determine the asthma severity and control. We need to do education for home self-management. Education's huge, right? And then, of course, looking at control of environmental factors that can contribute to symptoms. So controlling whatever the allergen trigger is. And of course, there's pharmacologic management and therapy. So that's usually defined as those quick relief measures as well as long-acting medications to help control symptoms. So before I go into talking about therapeutic management, like I said, asthma education is absolutely important. Making sure families understand what medications are used for, if they're short-term relief or quick relief type measures, or these long-term, more preventative type medications. If there's allergens that are triggering the asthma, again, there could be allergy medications that we take, and we'll get into those in the therapeutic management a little bit more. But making sure family really understands what the medications are for, when they need to take them, or how often they need to take them, and again, how to give them, whether it be an actual handheld nebulizer treatment, or if it is a mask nebulizer, or certainly doing like a albuterol type puffer or some sort of inhaler that they're actually using. If they would actually even need to use, if the child is younger and is not good at doing like those puffer type inhalers, using a spacer with that. So making sure they have all of their information that they needed about equipment and medication, and when to seek treatment. Again, looking at their oftentimes what we call an asthma action plan, and making sure they're able to do the peak flow monitoring or whatever is needed for home care. So just a fun little clip. If you've ever watched the show House, there's a funny little clip just about how important education is and making sure our families and our patients understand what their medications are for and how to use them properly, as well as the not so funny side of it. There's a good video, the asthma attack example is a great video. It's not terribly long. It's maybe 10 to 15 minutes, I think. And it just really shows kind of what's happening during an asthma attack, what's happening inside the body, and what typically, as a medical side of things, how do we manage that to help get things under control and relieve a lot of those asthma symptoms that we see. So, good video just to see kind of what's happening in the body with an asthma attack. In regards to therapeutic management with asthma, our primary goal in asthma management is prevention of airway inflammation. So for your blank, airway inflammation. The child who has mild intermittent asthma, so an example of that would be like maybe exercise-induced asthma. They can be prescribed an inhaled short-acting beta agonist like albuterol, PRN, or just as needed. So that's usually kind of like your quick relief medication for asthma. Children who have more persistent or severe symptoms, they typically are going to need an inhaled corticosteroid daily to prevent exacerbations. So you might want to go review that box about fluconazole. Some other medications that we can give them, especially triggered at controlling allergen type triggers or symptoms. There's all different ones out there, but there's leukotriene receptor agonists, like that would be the brand name is Singular, an inhaled long-acting beta agonist, immunomodulators, mast cell stabilizers. So really any of those like Allegras, Claritin, Zyrtec, of course I'm giving you all brand names, those things can really help with a lot of those allergens that we can't necessarily get rid of in our environment. There's also oral corticosteroids. We can give those, especially in acute exacerbations, to help get some of that inflammation down and relieve some of those symptoms. I definitely recommend going through your ATI book and looking at the nursing care and the interprofessional care for asthma. There's just way too much to put in your notes. It would make them even longer. So definitely go through and review under your asthma and your ATI about the nursing care and interprofessional care. It does a great job of summarizing it, as well as the teaching. I would go look at the ATI book for client education. So those are all good examples, or no, I shouldn't say examples, but good information of what kind of things we need to be teaching or what we need to be doing in our care. And the last thing I'm going to say before I wrap this slide up is complications of an asthma exacerbation would certainly be going into status asthmaticus or even respiratory failure. In the next few slides, I'm not going to record anything on them, but they are just different examples of the different types of ways that we can give different treatment measures, whether it be an inhaler, like in this picture, he's got an inhaler with a spacer, and teaching a child to use that, or just using just the inhaler, like the little puffer itself, and then certainly different ways that we can give nebulized treatments. The next topic we're going to talk about is status asthmaticus. So kind of going on further with not just talking about asthma, but what happens when we can't get those asthma exacerbations under control and it gets into the point of what we refer to as status asthmaticus. That is considered a medical emergency. So for your blank, a medical emergency. And it is a severe and prolonged asthma attack that is not responsive to asthma therapy. So for your second blank, is not responsive to asthma therapy. So it usually requires hospital evaluation and close cardiopulmonary monitoring. Assessment-wise, the child is in acute respiratory distress when they come in, and the child has failed to respond to their first-line therapy. So meaning with their asthma action plan, they know if they're getting in kind of to that red zone and they've tried there are treatment measures that are prescribed for them and it's just not improving, that is considered they're not responding to that first line therapy. So whether it be a nebulized treatment, a quick relief like albuterol or something like that, they're not responding to that. So what we will typically see when it comes to signs and symptoms or clinical manifestations that we're going to see, they're going to have what happened with their heart rate and respiratory rate, do you think? Hopefully you're thinking it would be increased, and that would be correct. So heart rate and respiratory rate are increased. They're working harder to breathe, harder to get that air. That airway is certainly a lot more narrowed because of the inflammation. So again, in turn, our heart rate and respiratory rate are going to be elevated. Their level of alertness and responsiveness may be altered. Why do you think that may be altered? And think about, what does their gas exchange or air exchange, what do you think it looks like? Well, they're probably having decreased level of alertness and responsiveness because, again, their O2 exchange isn't great. And if we're not getting good O2 exchange, that's happening throughout the body. So also think about mentally our level of consciousness. If we're not getting enough oxygen up to that brain because we're not getting it in our body all together like we should be, that's going to affect that level of alertness. They often appear anxious. I would too if I felt like I couldn't breathe and this had been going on for a while and I'm not getting relief from medication. So they appear anxious. Their O2 and their PO2 level are going to be, what do you think? It's going to be decreased, right? Remember, we don't have good air exchange, so our O2 and PO2 are going to be decreased. Our PCO2 is going to be increased. Why is that? Well, that's because those bronchi are so restricted, child can't exhale. If they can't exhale, that means we're hanging on to our CO2. So our CO2 is going to be increased, which means they can also rapidly progress into or lead to acidosis. Right? Their breath sounds can be limited, and that's just because there's so little air movement. So our therapeutic management for someone who comes in with status asthmaticus, what we're going to do is give them, for your blanks, continuous nebulization with an inhaled beta 2 agonist. So for your blanks, continuous nebulization with an inhaled beta 2 agonist, which a beta 2 agonist is, guess what? What's an example of that? Albuterol, right? So simply giving them albuterol. So even though they call it continuous, it can be continuous, or sometimes what you'll actually see is they'll administer 3 nebulizer treatments of albuterol, sometimes back to back, one right after the other, or they may space them out 20 to 30 minutes. So it just depends on the child and how quickly are they responding and what they need. So again, we usually do continuous nebulization of a beta 2 agonist like albuterol, either back to back, or we will do them no more than 20 to 30 minutes apart. We can also get an IV started and give them an IV corticosteroid along with either oral or IV steroids to help get that inflammation under control, and also help give them a smooth muscle relaxer as well. So if you watch that video of an asthma attack, that child is definitely in status asthmaticus, and some of the treatment measures that they did are exactly what we're talking about here. So again, hopefully those things work and we don't get into the point where we have to actually intubate or mechanically ventilate a child. But certainly if what we're doing isn't working, we want to make sure we are able to establish an airway. So in some cases, we may even need to do an ET intubation and mechanical ventilation just to make sure we have effective ventilation and perfusion. Our next lower respiratory tract disorder we're going to talk about is pneumonias. So I'm only going to really focus on one, but pneumonias in general are infection and inflammation of the alveoli, and it can be bacterial or viral in origin. It's usually categorized as either hospital or community-acquired pneumonia. More common in late winter and early spring. And the one we're going to focus on is pneumococcal pneumonia. again, for the most part, pneumonia is pneumonia. It looks pretty similar in adults and kids. Our treatment measures are pretty much the same as long as they're responding to that treatment measure. We're not going to really do anything too differently that you wouldn't already be doing the same thing for an adult. So, pneumococcal pneumonia, the onset is generally abrupt and it follows an upper respiratory infection. So, URI is upper respiratory infection. For infants, that infection tends to be bronchopneumonia and they have poor consolidation. Where in older children, it usually will localize to a single lobe with full consolidation. So in this picture, what you can see on the x-ray is see that red outline box that's showing you that consolidation, that white, I don't really want to call it patchy because it's not patchy, but that white consolidation. So this is probably a little bit older child where it has actually consolidated to that single lobe. So again, especially with older children, during the first or initial 24 to 48 hours of the infection, they may also have blood-tinged sputum, and that will transition to thick and purulent sputum. Assessment-wise, the child appears acutely ill. You can tell they look sick. They don't look well. They have a high fever. They may have some tachycardia. Their breath sounds can be diminished, or they could have crackles, or what some people refer to as rales. They're complaining of chest or abdominal pain, depending on where that pneumonia is in the lung or where it has consolidated. Sometimes their pain will be complained about in different areas. So kids aren't going to necessarily complain like an adult. That is something that is different. They may complain more about abdominal pain, especially if it's in the lower lobes. They may complain more about abdominal pain. They might complain about some chills or experience chills, and they have different signs of respiratory distress. We can hear dullness on percussion, and that indicates total consolidation. When it comes to diagnostics, again, we typically are going to do a chest x-ray, and that will reveal that consolidation. So like I said before, in that red box or that outline box is that consolidation. So that white area is where that pneumonia is. And then we can certainly also do lab studies, and we can see the big thing we're really looking for is we can see leukocytosis. So typically with the lab studies, they're probably just going to do like a CBC with diff. They may get also, people call it different things, a basic metabolic panel, so BMP or CMP, which just means complete metabolic panel. And just because they may want to look at like hydration status and things like that. Probably the most important would be your CBC with diff and looking for leukocytosis. So our therapeutic management for pneumococcal pneumonias, our pharmacologic management, we're going to give them IV fluids to make sure they're staying hydrated. Antibiotics, because again, pneumococcal tells you it's bacterial, or most commonly tells you it's bacterial. And they need antipyretics for that high fever because of the bacteria that's causing it. We also want to make sure we're checking their oxygen saturation levels frequently, giving humidified oxygen as needed or supplemental. Even if they're maintaining their sats in the low to mid 90s, it can also help them with reducing that labored breathing and trying to prevent hypoxemia. So even though maybe they're satting halfway decent, maybe not quite the upper 90s, that oxygenation can help with their labored breathing, so they're not working so hard. Ease that respiratory effort a little bit. We can also do CPT or chest physiotherapy, and what that's going to do is help encourage the movement of mucus and prevent obstruction. So trying to loosen that up, and hopefully we want to encourage them to cough and try and move some of that mucus. We also want to reposition the child frequently, especially if they're not able to do it themselves, or certainly encourage them if they are able to do it themselves to reposition, because we want to prevent pooling of secretions. And the reason we want to prevent that is we know that a pooling of secretions, again, think about the lungs, nice, warm, moist area, great breeding ground for bacteria. So we don't want to make the infection already worse. We want to make sure again, we're constantly moving them so that fluid doesn't have a chance to build up and create more problems. Our next disorder we're going to talk about is cystic fibrosis, or often referred to as CF. It is an inherited disease of the secretory glands. So it is inherited as an autosomal recessive trait. So for your blank, autosomal recessive trait, which just means both parents must have trait for the child to have disease or potentially have disease. It occurs in approximately 1 in 2,500 live births, and it is most common in Caucasian children. So just going back to kind of explain genetics a little bit, like in this chart, both parents must have trait, which just means neither parent shows signs or symptoms. They're basically carriers of the disease. So the chances that their offspring, and this is the same chances with each pregnancy that they may have, there is a 1 in 4 chance or 25% chance that their child will actually have cystic fibrosis, meaning they have disease, they have signs and symptoms. There's a 1 in 4 or 25% chance the child will not have anything, meaning they don't even carry the trait. So no disease, no symptoms, and they're not a carrier. So that means with that child's offspring, when they have offspring, they cannot possibly pass it on to theirs. They have a 2 in 4 chance or 50% chance that their child that they have with a pregnancy will carry the trait. But if the child is carrying the trait, that means they do not have the disease, they do not show signs and symptoms. So with every pregnancy, it's the same risk. The biggest thing is, again, the 1 in 4 or 25% chance that their child will actually have disease and show signs and symptoms. So cystic fibrosis is characterized by thick mucus secretions that are primarily in the pancreas and the lungs. And those are kind of the two big areas that we're going to talk about and how that affects them, because that's mostly where they have a lot of their problems. But we also see some other problems elsewhere in the body. They have electrolyte abnormalities, especially in their sweat gland secretions. So when we talk about diagnostics, there's a lot of things that we can do to detect this and certainly document it. If both parents know potentially that they or I shouldn't say potentially, that they know they have the trait, or even if they don't, if they choose to do chorionic villi sampling or amniocentesis during pregnancy, they can detect this for early detection. All newborns, no matter what, part of their newborn screen are screened for cystic fibrosis, but it is just that. It's a screening tool. It does not give them a definitive diagnosis whether the child has trait or whether they have disease. So newborn screening tool, it's just a screening tool to go, hey, maybe potential red flag, we need to do some more testing. It cannot distinguish between trait and disease. They can also detect by doing some documentation of some other things. They can look at chromosomal abnormality. They look at, because of their abnormalities in their electrolytes, they can look at the abnormal chloride concentration in their perspiration, which we'll talk about that a little bit further later. They look at the absence of pancreatic enzymes in the duodenum, and they look for the presence of immunoreactive tyrosipsogen in the blood, second to a pancreatic obstruction. And they also look at the extent of pulmonary involvement. So they do that for disease and documentation and diagnosis for cystic fibrosis. Right, so now we're going to talk about how it involves or how it affects the pancreas. And just a little bit ago, I had said that there was an absence of the pancreatic enzymes in the duodenum. So for your blank, pancreatic, absence of pancreatic enzymes in the duodenum, which means if there's an absence of the pancreatic enzymes, they have an inability to digest fat, protein, and some sugars. So what ends up happening, because they can't digest these things, it really affects what their bowel movements look like. Um, they're large, they're bulky, and they're greasy. So that stearrhea, or sometimes people will refer to them as the 4 Fs. They're frequent, they're foul, they're frothy, and they float. Because guess what? When they can't digest fat, especially, um, think about if you've ever had something that was really greasy, didn't agree with your body, what happens? Kind of shoots right through you, right? Well, guess what? Fat or oil and water don't mix. So again, their stools kind of have, again, those 4 Fs. They're frequent, they're foul, and they're frothy, and they float. Um, because of that inability to digest fat and protein, it certainly affects their nutritional status. And I'm going to come back to that in just a little bit. But we also see, because of the pancreatic involvement, there's an increase in their intestinal flora and their fat results. So again, goes back to those 4 Fs. It's extremely foul odor, and they have an increase in the bulk of their stool, which really means not that the stool is more formed itself, it's that there's a lot of it, because again, we're not digesting it. The body's not absorbing those nutrients. So they have an increase in the bulk of their feces, which can also lead to a protuberant abdomen. So kind of an abdomen that's kind of sticking out a little bit. However, they often do have malnutrition, especially if we're not addressing it with therapy. So they tend to have more emaciated extremities. They can have some loose skin folds on their buttocks because of that malnutrition. And if you've ever seen those little kids, and especially like in foreign countries, excuse me, who are malnourished, they tend to have that protruding abdomen, but they have those really skinny legs and loose skin folds. That's because of malnutrition. They also, because of the inability to digest fat, they can't digest fat-soluble vitamins, because those can't be absorbed in the absence of fat absorption. So particularly our fat-soluble vitamins are what? There's 4 of them. Particularly vitamins A, D, E, and K is considered part of that fat-soluble vitamins. But the book is only going to tell you particularly vitamins A, D, and E. It can result in vitamin deficiency because we're not absorbing. The reason we're not absorbing, we've got all that thick mucus, remember, that's affecting the pancreas. It can't digest fat because we're lack of the absence of the pancreatic enzymes. So all of that all together is causing a whole lot of nutritional problems and nutritional deficiencies. The way we may suspect this in the newborn period that they have cystic fibrosis, especially if we have no idea, or parents have no idea that they are carriers of the trait, or they've never had any other children, and there's maybe not a real well-known family history. There's some things we can look for that we may suspect cystic fibrosis during the newborn period. And the first thing we are going to look for is what's called a meconium ileus, which just simply means a failure to pass that first stool, or the meconium, within 24 hours of birth. So failure to pass stool within 24 hours of birth. And what happens is if they don't pass that stool, it can lead to developing abdominal distension. And if we see that, then we need to do further evaluation and investigation. The infant also tends to fail to regain that normal birth weight within 7 to 10 days after birth. So you probably haven't talked much about that yet, maybe in OB, but we know when baby's born, we weigh them, we get that birth weight. They're going to lose, in a matter of the first few days, they're going to lose a little bit of weight. That's expected. But they should gain that weight that they lose right after birth back within the first typically 7 to 10 days. So for these kids with cystic fibrosis, they fail to regain that normal birth weight within that 7 to 10 day window after birth. And again, that's not partly, it is because it's secondary to the infant's inability to absorb milk fat. Doesn't matter if we're talking breastfed or formula fed, they're not absorbing that milk fat that they're getting. Because again, they have a lack of those pancreatic enzymes, which means they cannot digest fat and protein properly. Children, if they go undiagnosed at birth, we tend to start seeing a presence of, or it's becoming present with complaints of increased hunger. So these kids tend to have, at least in the beginning, very ferocious appetites, but yet they're not gaining weight like they should. And we also see those steroretic stools, or those greasy stools, because the stool changes are inconsistent with simple colic. So whenever we're trying to rule out or figure out different things, this is one of those things what we look at and ask about their stools. What do they look like? What's the frequency? Because really we're trying to rule out other things before we go into more involved testing. Next, we're going to look at how does cystic fibrosis interfere with lung involvement, or with the lungs. So their anterior-posterior, or A and P, chest diameter actually becomes enlarged over time. So this is not something that necessarily we see in the newborn or infant period, but over time with cystic fibrosis, we see that anterior-posterior chest diameter become enlarged. Why do you think it would become enlarged? If they've got all that thick mucus thinking about respiratory and it's blocking, guess what? They're going to end up having poor air exchange. Think about an adult who has COPD, right? They get that barrel chest, the hyperinflation. It's really the same thing with someone with cystic fibrosis. Same idea. Not the same pathophysiology, but why that anterior-posterior chest diameter becomes enlarged. So for your link, it becomes enlarged. Again, the thickened mucus pulls in those bronchioles, which leads to, guess what? Think about lungs. Nice, warm, moist breathing ground. That mucus it can't get out. It's so thick, it's trapping bacteria. So it's going to end up leading to frequent infections, right? So most commonly cultured organisms you can see there, I'm not going to go through all of them, but Staphylococcus aureus, Pseudomonas, H. influenza, there could be some other ones, but those are the most common ones we see. They also end up, again, over time, because of that thick mucus and the poor air exchange, they can have atelectasis, so absorption of air from the alveoli behind those blocked bronchioles. And again, over time, because of poor tissue perfusion, we can see clubbed fingers or nails, which again, like I said, just tells you inadequate peripheral tissue perfusion. They typically will start to develop respiratory infections around 4 to 6 months of age. And with their respiratory assessment with someone with cystic fibrosis, we're going to have wheezing and rhonchi on auscultation. They have chest hyperresonant with percussion, and they have a cough. And the cough is the most prominent finding by preschool age. Okay, we're going to talk about other things that we certainly look at and for documentation purposes of cystic fibrosis. And next we're going to talk about sweat gland involvement. The sweat glands themselves are not changed in the structure. It's the level of chloride to sodium in their perspiration. It is 2 to 5 times above normal. So it leads to this salty taste or perspiration. No, that does not mean we go around licking children. But oftentimes parents will say when they kiss them, or kiss them because they're crying, or just kissing their face, their cheeks, that they often have kind of this salty salty taste when they kiss their children. So if we would test, what we can do is some sweat testing, and that detects the abnormal salt concentrations. We do this by a paper analysis, and we look at that sodium chloride content. So normal, someone who does not have cystic fibrosis, would be around 20 milliequivalents per liter. With someone who has cystic fibrosis, when we do sweat testing, again, remember they're 2 to 5 times above normal. So that means they're greater than 60, or anything greater than 60 milliequivalents per liter equals a diagnosis of cystic fibrosis. We also look at doing a duodenal analysis. We look at those secretions, and we use that to detect pancreatic enzymes. That helps us reveal the extent of the pancreatic involvement. We do this by passing an NG into the duodenum, and we aspirate secretions for analysis. We'll place those secretions and determine them by a pH level, or we can do a placement and determine by pH level, And the secretions are sent off to the laboratory for analysis of the trypsin content, and certainly that is the easiest pancreatic enzyme to assay that we can test. Next, we can also do a stool analysis, and that would be important to do, and we may do this not just at time of diagnosis, but sometimes throughout their lifetime and management of cystic fibrosis. Stool analysis, we do that. What we're going to do is just simply collect stool, and we want to analyze it for what do you think? We want to analyze it for the fat content, right? So we're going to analyze it for fat content because remember, lacking those pancreatic enzymes, we can't digest and absorb fat normally, so that's going to go out through the stool, leading to those frequent foul, frothy, and floating stools. So we want to assess how much fat content is in the stool, and we can also assess for the lack of the trypsin. And the last thing I'm going to talk about when it comes to kind of diagnosis and documentation is we would want to do pulmonary testing. So we can do chest x-rays that can help confirm the extent of pulmonary involvement. And again, this isn't something we just do at the beginning for diagnosis. The chest x-rays is something we can do on a frequent basis, especially when they come in with exacerbations of cystic fibrosis or active infections of the lungs. We want to do chest x-rays. We can also do pulmonary function tests. Those are really important throughout their lifetime of care because that can help determine the extent of atelectasis and emphysema as well. The pulmonary function test can also give us a good picture of when they come in with exacerbations. Is the treatment that we're doing, are we seeing improvement in those pulmonary function tests? And if we are doing treatment that's working for them, we should see an improvement. They usually, when they come in with exacerbations, they will do them at periodic intervals. Usually, like I've seen them do them every Monday, Wednesday, and Friday, or every Monday and Friday of the week, because they want to see how that treatment is improving. Okay, let's talk about the therapeutic management involved for cystic fibrosis. It is a collaborative process to decrease the involvement of the pancreas, lungs, and sweat glands. So focusing first on pulmonary management, a large amount and the viscosity of the respiratory secretions is what contributes to the likelihood of, what we say earlier, respiratory infections. So for your blank, the likelihood or contributing likelihood of respiratory infections. Again, lungs, nice warm spot. We've got thick mucus. So again, that thick mucus in the warm, moist areas of the lungs promotes the growth of lots of different organisms. And unfortunately, some of those are obviously bacterial agents. We want to assist in part of that pulmonary management. We want to assist in providing airway clearance to help promote the expectoration of pulmonary secretions, so that mucus. So we do different things to try and break that up or help try and move that out and get rid of it. One of those things is chest physiotherapy or CPT, along with postural drainage. So in the next couple slides, I'll have a couple examples of those. But with our pulmonary management and doing CPT, we want to be doing that. So right below those two little pictures, your blank, at least twice daily and PRN. So twice daily and PRN. And we want to increase, for your next blank, increase in times of infection and hospitalization. Something else we can also use to help break up some of that mucus to help with expectorant of it is something called a mucus flutter device or a flutter mucus clearance device. And what that does is when they blow into it, it basically causes like a vibration to help break up some of that mucus. The idea to help them be able to cough that up and expectorate that. Next, we also can do further pulmonary management, administer aerosol therapy. So one of those that we can do are different types of bronchodilators. So an example, like short-acting beta-2 agonists like albuterol. Do understand too, and I didn't talk about this back with asthma, but side effects of albuterol, you would want to monitor for tremors and tachycardia. Those are very common with albuterol. Another bronchodilator that could be used is a cholinergic antagonist or anticholinergics. An example of that would be like Atrovent. If they're getting Atrovent, we would want to observe for a dry mouth. So doing some good mouth care as well with that. Another broncho dilator that can be used is fluconazole or like an Advair discus. It would be important to teach them to make sure they rinse their mouth afterwards. And why might that be? Well, again, if we're not rinsing their mouth out, because again, the type of medication, the fluconazole, they're more likely to develop thrush if we're not doing proper mouth care after the use of that drug. And then the last one we're going to talk about with bronchodilators, or certainly just different pulmonary measurement or management measures, is something called Dornase alpha or Pulmonize, and that's given via a nebulizer treatment. That is important for somebody with cystic fibrosis because it's going to actually help decrease the viscosity of the mucus. So if you're blank, decrease viscosity of mucus and help improve lung function. So when a patient is getting the Dornase alpha via nebulizer, we would want to monitor their sputum thickness and their ability to clear that mucus, so cough it up. And we would also want to monitor for improvement in the child's PFTs or pulmonary function tests. So remember when I said though, during times of exacerbation, they will go frequently and check their pulmonary function test to see if the therapy we're doing is helping to improve that pulmonary function. And again, Dornase alpha is that one of those drugs that we're going to use. So again, we want to monitor their PFTs, and if our treatment is working, we should see an improvement over time. And the last couple things I want to talk about under pulmonary management is oftentimes they also may need IV or aerosolized antibiotics as well because of those bacterial infections. We want to make sure we encourage not just when they're healthy at all times, especially when they're healthy though, getting physical aerobic exercise because that can really help with strengthening the lungs, helping with lung expansion to try and help deter some of these infections and exacerbations that they get into. We also want to provide oxygen as prescribed or as needed. Again, because of that thick mucus, and they often have poor tissue perfusion as well. And atelectasis, they may need, especially during a CF exacerbation, they may need some supplemental O2. They may even have to use supplemental O2 at some point in time in their lifetime on a regular basis, not just during hospitalization. Right, continuing on with our therapeutic management and now talking about gastrointestinal management, we want to make sure we're providing a well-balanced, high-calorie and high-protein diet. And that's really to help support growth and development. So high-calorie, high-protein diet. That thick mucus in the GI system doesn't allow for, what did we say? Absorption of nutrients, right? As well as the fact that we're lacking pancreatic enzymes. So that thick mucus does not allow for absorption of nutrients. We want to monitor the amount of what in their diet? We want to monitor the amount of fat in their diet. So monitor fat in their diet because it is poorly digested. So for your blank, monitor fat in the diet because it's poorly digested. We'll make sure we're also encouraging oral fluid intake, just making sure they stay well hydrated. And we know, especially anytime you've got like a respiratory infection or a lot of mucus, it's always good to drink lots of fluids to help break that up and try and thin those out a little bit. So encouraging oral fluid intake. We also want to make sure what's really important is that, remember, they're lacking those pancreatic enzymes, so we want to make sure we provide those. So administer pancreatic enzymes anytime they eat, meal, snack, doesn't matter. Within 30 minutes of eating that meal or snack, they must take pancreatic enzymes. So for every kid, the amount that they take, that varies over the course of their lifetime. Those often need to be adjusted, but it is important to make sure they are taking those anytime they eat, meal, or snack. You might want to also go back and look at that particular box and review the responsibility for administration of pancrealipase, which is the pancreatic enzymes. We also need to make sure we administer a vitamin supplement because remember, they have vitamin deficiency. They're not absorbing those vitamins, especially the fat soluble vitamins. So we want to give them a multivitamin. And for those fat soluble vitamins, I promise you it's not a typo. Because those fat soluble vitamins, A, D, E, and K, are so poorly digested, we want to actually give those vitamins in a water soluble form to make it easier for them to digest. So oftentimes when they have a multivitamin, it'll say, what I've seen on packages is aqua, it says like aqua vitamins or aqua something with the vitamins. And that's because we want it in a water soluble form so that they're more likely to absorb it or have better absorption with water soluble form of A, D, E, and K. Again, given because the fat soluble vitamin absorption is, for your blank, decreased. Fat soluble vitamin absorption is decreased. So we want to give it in a water soluble to promote better absorption. They often too will need laxatives or stool softeners because of constipation. Usually what we can give them is that polyethylene glycol, or you're probably more familiar with the brand name Miralax. That can be given PO or even through NG if needed. Many times they'll also develop a GERD over their lifetime or during the course of their life with cystic fibrosis. So we can give them a histamine receptor antagonist and a motility medication for that GERD. And sometimes, even though in the beginning I said their appetite is really kind of ferocious and they're just eating, but they're not really gaining any weight, they're not growing like they should, eventually that kind of, their appetite kind of drops off. And sometimes they're not able to take in much. They're with the GERD and just with the, not the atelectasis, but the vitamin deficiency and things that happen, they often kind of start to lose their appetite as they get older or don't have as good of an appetite. And so sometimes we need to give them formula supplements. As an infant, we may even need to do that in addition to breastfeeding. And it can be done if they can't take it by PO, then sometimes kids or down the road, they will get a G tube to make sure they're getting adequate nutrition. So again, supplements are often needed just because we want to make sure we're still supporting that growth and development. So oftentimes too, they need to consult, or a dietitian will consult and help them make sure they're getting adequate nutrients for growth and development. So this slide is just an example of one way to do CPT or chest physiotherapy and that postural drainage that I talked about before and the need to do that. Again, the CPT, the idea is that that's just going to help break up that mucus, and especially for younger kids, we can do the postural drainage to help promote gravity, to help because they don't have, especially infants and toddlers and even preschool, even if they have a good enough cough where they actually will bring some of that mucus up, most times what's going to happen, they don't understand or know that they should spit that out. So by doing the postural drainage, the idea is that gravity will help when we loosen that up, that they'll be able to expectorate that and not just swallow it again. Because oftentimes, again, those younger ages, even if they have a strong cough to bring something up, they end up just swallowing it. So going into some of your teaching, we want to make sure we're promoting normalcy and a reasonable quality of life for a child and family. This is something that is lifetime. It's not something that we have found a cure for. There's lots of research going on. We've made lots of improvements in our care and life expectancy with someone with cystic fibrosis. It used to be they were lucky if they made it to their teenage years, and now they're living into adulthood. And again, there's still some who are a little worse off or better than others. It depends too how compliant they are with therapy and medication, because this is something they have to do day in and day out. They can't take a day off. They can't just go, I don't feel like doing it today. It's really just not an option for them. So that gets kind of old with a chronic disease and can be challenging. But the more that they keep up with their care and doing the things that they need to do, it certainly, hopefully, the idea is that will reduce um, their hospitalizations and prolong their life expectancy as well. It'd be important continuing with your education or teaching. Make sure family and child, if they're old enough, understand what the use of respiratory equipment is and how to care for the child and the different drugs and medications they need to be on. So instructing parent and child how to properly use a metered dose inhaler, that's what an MDI is, so metered dose inhaler or a nebulizer. Instructing parent and child on the frequency of administration of meds and respiratory treatments, instructing them about how to do CPT and different breathing exercises. We also want to make sure we're promoting regular provider visits. They should still be doing well child checkups. They should still be getting immunizations, especially like the pneumococcal vaccine, the influenza, because we really want to prevent those type of respiratory infections. So those are just as important. Teaching about diet and ways to increase calorie intake. So again, making sure we're supporting that growth and development. That is absolutely important. Teaching indications of infection and when to call the provider. Teaching about ways to manage chronic illness and having realistic life expectations and realistic goals. It doesn't mean, we don't want to promote the best for them. We absolutely do, but also making sure that they are realistic, because this is a lifetime disease. And like I said, there is no cure at this time for it. So again, managing that chronic illness in children. We want to promote regular physical exercise. That is still just as important, not only for their lung health, but just their overall health. And we want to encourage families to participate in support groups or use of other community resources, and especially even information about respite care. And we want to make sure we're identifying specific needs based on the patient's developmental level. So if you're educating the child or certainly talking to the child about what's going on, make sure it is at a developmental level that they can understand. And we also want to provide home palliative care for that child or adolescent who is in the terminal stages of cystic fibrosis. This last slide is just another example of a different type of therapy for kind of really doing the same thing as like manual CPT. This is called the chest, or I should say not chest, but vest physiotherapy. It does the same idea. They strap this vest on and they turn on the machine, and it basically vibrates to help kind of loosen up that mucus. And the idea is hopefully, again, that they can cough that up. So not every patient will have this, especially at home. It's very expensive, hard to get insurance sometimes to cover, but it is used frequently in the hospital more so. But some patients do have that at home, and they just, again, do this twice a day and increase in times of infection. So twice a day in PRN, and it's just the chest version of CPT, or I keep saying chest, the vest version of chest physiotherapy. Next disorder we're going to talk about is acute otitis media, which actually comes from chapter 50. It's often also referred to as OM, or just otitis media. It is actually inflammation of the middle ear. So for your blank, inflammation of the middle ear. Its peak age, or the peak ages that it occurs is between 6 months and 36 months, and again between 4 and 6 years of age. So for your blanks, between 6 months and 36 months, and then again between 4 and 6 years of age. So why do you think between especially 6 months and 36 months might we have a peak with otitis media? Well, a lot of that has to do with feeding methods, just anatomic features, enlarged lymph nodes, again, immature defenses. I'm going to go through those just a little bit more detailed here in just a second. And then again, think about between 4 and 6 years of age. Well, maybe if they haven't been going to a daycare or preschool and now they are, we're around other children, um, and again, not good hand washers. That's not how you get otitis media, but just thinking about the viruses and colds, and then it creating inflammation in our respiratory tract or inflammation with our tonsils or adenoids, that affects the way the eustachian tube drains, which then can certainly affect inflammation and fluid buildup in the middle ear. So, most susceptible are males, um, as Alaskan or Native American, children who have cleft palates as well. Otitis media tends to be worse in winter and spring because it frequently follows that upper respiratory infection. Again, some of those predisposing factors, we have anatomic features. The eustachian tube in children compared to the adult is short, straight eustachian tubes, and they're poorly developed cartilage lining, which makes that eustachian tube open prematurely and have improper drainage. So in this slide that we're on, you can see the comparison of a child's eustachian tube. Again, it's shorter, it's wider, it's straighter compared to the adult who has narrower, it's got more of a curve, and it's longer. All of those things make a difference as to how bacteria or fluid flows through through the eustachian tubes and into the middle ear. We also see with kids enlarged lymphoid tissue. That enlarged lymphoid tissues, those adenoids that we talked about, more of the adenoids than like the palatine tonsils. The adenoids themselves can block the eustachian tubes if they're really enlarged. So then we don't get proper drainage. Again, think about kids in general and especially babies, the 6 to 36 months. We have immature defenses, so they're at increased risk for infection. And that is true as well with your 4 and 6-year-olds, still immature compared to obviously the older child or even the adult. Um, Relationship to feeding method plays a role. So, infant fed formula, or I say infants who are formula fed versus breastfed. Um, Infants who are breastfed tend to be held in a more slanted position when they're nursing. So that allows milk um, to enter the eustachian tube. And then, of course, um, where more bottle feeding, especially once they're able to hold, if they are laying flat, again, that can allow fluid movement or milk into um, the middle ear. Passive smoking certainly increases the risk as well because it's an irritant to the eustachian tubes. So again, we've talked about that a few times through respiratory, how important it is to eliminate secondary tobacco smoke, smoke that's on the parent's clothing and not going in and picking up a child or infant, because that secondhand smoke is very irritating and causes that irritation, which can then cause the inflammation and progress things. This slide is really just a comparison of pictures of what the eardrum and tympanic membrane can look like um, normal compared to the different types of otitis media. So obviously the first one that says normal, that's what it should look like. It's kind of got like the opaque appearance to it. No redness or anything like that, no fluid. Where otitis media, the next one that just says OM underneath it, you can really see the inflammation and redness. There's no fluid there. It's just inflammation and redness in that eardrum and the tympanic membrane. Where effusion means there's fluid buildup there. So you can see those bubbles of fluid behind that tympanic membrane. Um, and there's, again, redness and inflammation as well. And then OM with exudate or otitis media with exudate. That exudate is, again, actually like bacteria or pus that has formed that usually tells you, again, some sort of infectious process. Again, it's red, it's inflamed, you can tell it's very irritated. So then again, nice just examples of what it would look like if we visualized checking those ears for otitis media. The assessment for otitis media, again, otitis media usually follows a respiratory tract infection, so the children tend to have some sort of cold or rhinitis, maybe a low-grade fever for several days. And then suddenly what will happen is they will spike a fever to about 102 or somewhere in there, 102 degrees Fahrenheit. They may complain about sharp, constant pain in one or both ears. And especially for older children, pain and pressure are the cardinal signs. So if you're blank, are cardinal signs. Pain and pressure are cardinal signs. If they would all of a sudden say they have a relief of pain or there's drainage coming from the ear, that potentially means that the eardrum itself has ruptured, and that's not a good thing. For infants, they can't tell you they're having pain. They can't show you or say that they're feeling pressure. So we look for some other symptoms in infants. They may be crying and fussy and restless and irritable. They tend to also rub, pull, or hold the affected ear. Again, for older children, they can verbalize that pain. They can point to where the pain is, meaning which ear it's in. They can really kind of tell you what it feels like compared to the infant. Diagnostically, we certainly look at clinical manifestations they're exhibiting or complaining about. We can do a visual inspection of the tympanic membrane. It's again usually red, bulging, and inflamed, like in the previous slide's pictures. And we can also palpate the mastoid process behind the ear. That would be important to do. And we're really looking to see if it's tender to the touch. Because if it is tender to the touch, that tells us the infection has actually more than likely spread out of the middle ear and into the mastoid cells. If that's happened, it can be a serious complication of that infection, could lead to actually meningitis. So again, that would be important to palpate behind the mastoid process and to see if it is tender to touch, to see if that infection has spread. Our therapeutic management for otitis media. Most of them do resolve spontaneously, so we don't typically encourage, families or to take their kid to the doctor as soon as they start complaining about ear pain, because again, oftentimes it's a result of that cold. So we wait a day or two to see if it gets any better. I mean, obviously, if they're in significant pain, that's a different story. But if it's not bothering them too bad, we usually might wait a day or two, see if it resolves on its own, because then antibiotics aren't recommended. If it does not resolve spontaneously on its own, then they're probably going to need antibiotics. Typically, what we prescribe first, or the doctor would prescribe first, is amoxicillin, and that is for bacterial infections only. We would only be giving antibiotics for a bacterial infection. Some other pharmacologic management things that we can do: an analgesic or an antipyretic, so Tylenol, ibuprofen for fever and pain. Decongestant nose drops can be used. That can help open the eustachian tubes and allow for air to that middle ear, allow for drainage, help decrease some of that inflamed tissue, the eustachian tubes. But we want to be careful how long we give that for. So we only want to give it for 2 to 3 days, because we want to avoid what's called a rebound effect, which is where the edema and the subsequent increase in mucous membrane inflammation actually gets worse. It will come back. So we would only want to use a decongestant nose drop for 2 to 3 days. And again, provide a smoke-free home environment that can help prevent further episodes. For some children, they do experience conductive hearing loss as well. So that can last as long as 6 months after an acute otitis media infection. So we want to caution parents, don't think that the infection is getting worse or that, didn't clear that infection. It's just something that can take some time to completely resolve. So if they would still have conductive hearing loss after 6 months, then they definitely need to be reevaluated. All right, our next one we're going to talk about is otitis media with effusion. So otitis media with effusion is when you have otitis media that has become chronic, as well as not just there's there inflammation present, there's also fluid. So you have inflammation and fluid in that middle ear space without symptoms of an acute infection. So they have feelings of fullness in the ear. They may complain about, especially older children, may complain about having like muffled hearing. It most typically occurs frequently in ages 3 to 10 years of age. And then again, assessment-wise, they complain about muffled hearing, feeling of pressure in their ear, and on visual inspection, we can actually see fluid behind that tympanic membrane. So in this picture is an example of where you're seeing that fluid behind the tympanic membrane. Our therapeutic management for otitis media with effusion, it can be long-term in some cases. If the condition appears to be intensified by inflammation from an allergy, then we certainly want to take measures to control that allergy that initiated it. So ideally, if we can avoid whatever that allergen is, avoid it or get rid of it completely. Sometimes that's not possible. Something else we can do is something called hyposensitization, which is really getting at the idea behind allergy shots. Those allergens that we can't necessarily avoid or get rid of, then we can certainly do allergy shots to help kind of build up, or what we call hyposensitize the body to whatever that allergen is. We can also do pharmacologic alterations for that allergic response. And our medical treatment is really aimed at supplying air to the middle ear. So in some cases, they may prescribe like a daily administration of an antihistamine or a nasal decongestant. Again, the idea is that's going to shrink that mucous membrane of the eustachian tube. We can also remove the enlarged adenoids if that's blocking the eustachian tubes to allow them to drain better. Another method they can try is something called tympanocentesis, and that's where we actually remove the fluid from the middle ear by insertion of a needle through the tympanic membrane. And the last thing, which is what the pictures on this slide really have to do with, or the one picture has to do with, is something called a tubal laryngotomy. And that's when we place tubes in the middle ear to help, or not in the middle ear, but help to facilitate drainage of fluid and allow ventilation to the middle ear. So that second picture where you see that kind of like that little green tube, that would be the tube that they place. The tubes themselves tend to be extruded after about 6 to 12 months just on their own. They'll fall out. They're not sutured in place or anything like that. They'll fall out on their own. In some cases, they do have to be removed by the physician, but most times that can just be done in the physician's office. In some cases, they fall out a little bit too early, and kids continue to get otitis media with effusion. So or that chronic otitis media. So there are times where the tubes themselves have to be repeated. Important to educate the family in the care of the child who has tubal laryngotomy done. Want to make sure that they're wearing earplugs in water while swimming, bathing, or showering. We would rather them bathe than shower because bath water and shampoo need to be kept out of the ear, and that's a little bit easier to control during a bath than it is during a shower. We need to make sure we're teaching them ways to prevent otitis media. So if we have an infant, making sure they're sitting holding the infant upright during the feeding so that fluid cannot be retained in that middle ear. We want to teach them to make sure to recognize signs of otitis media early so that they can get proper medical care and that it doesn't become a chronic issue. And of course, eliminating tobacco smoke and any known allergens from the environment. So for your blank, eliminate tobacco smoke. Complications from having otitis media with effusion. Again, thinking about this as a chronic, more of a long-term issue. So they can have hearing loss and mastoiditis. Our next disorder we're going to talk about is submergent injuries or drowning. Drowning is death caused by suffocation from a submersion in liquid. So inhaled water fills the lungs and therefore it blocks the exchange of oxygen in the alveoli. A near drowning is considered a child who survives the first 24 hours after an injury because of the emergency treatment that they received. So for infants, a near drowning most common is in the bathtub. For 1 to 4 year old, most common is usually like those artificial pools. And for older children, it's most frequently in bodies of fresh water. So the majority take place outside of the home and especially in the summer months. And it could be contributed to a lack of supervision or just completely unattended. Swimming, oftentimes, especially I think about the older children, they can be overconfident or maybe lack the ability and they quickly get into dangerous situations. Not wearing life jackets when in the water. So again, if they don't know how to swim or aren't the best swimmer, life jackets are really important. Thinking about when maybe fishing, even if you're fishing on a dock or um, off a boat, you need to be wearing a life jacket. Anytime we're boating, kids need to have life jackets because accidents happen. The pathophysiology. When children's heads are submerged and inhalation of water occurs, they cough violently from that irritation of the water in their nose and throat. If they can't get their head out of the water is actually going to enter their larynx. The larynx will spasm and prevent any further water or air from entering the trachea, which then results in asphyxia. If the child is ventilated, treatment is very effective because little water is in the lungs. If there is no treatment and the larynx relaxes due to the asphyxia, then water is going to enter the lungs, which then means oxygen can no longer be exchanged because the alveoli will fill with water, which then leads to hypoxia, or that hypoxia deepens, I should say. They already have hypoxia, which can actually lead to cardiac arrest occurring. So, our emergency management for a drowning or near drowning. When they are pulled from the water after a near drowning, mouth to mouth resuscitation and CPR needs to be started ASAP. And they're going to need, even if they are revived, they still need to have follow up care at a healthcare facility. Because that child has or is certain to be acidotic from the accumulated carbon dioxide and hypoxic due to the water in the alveoli, they need to be checked out and cared for. Sometimes, even when they're revived, we don't necessarily see the immediate danger. Sometimes things develop in due time. So, and the other big thing is, I don't care what kind of water they were in or potentially swallowed or got into their lungs, they are at high risk of infection because of contaminants in water. So even if it was pool water, even if it was in the bathtub, there are still contaminants in the water. So again, they need to be cared for in a healthcare setting. So our follow-up care is really aimed at increasing the child's O2 and CO2 exchange capacity. We need to monitor their pulse ox. Definitely need to be assessing their lungs for adventitious sounds, so rales, fine rhonchi, monitoring their respiratory status overall, because if respiratory efforts remain severely compromised, the child is intubated and usually with a cuffed endotracheal tube and mechanical ventilation with a positive end expiratory pressure to force air into the alveoli. That cuffed tube is used because water that was swallowed will often be vomited as the child is revived, and the cuff actually prevents the vomit from being aspirated. They need to be given 100% O2, and they're going to place an NG tube into the stomach to decompress it to prevent vomiting and also to free up breathing space. Bronchodilator, like albuterol, may also be used to prevent bronchospasm and allow that child to make maximum use of the O2 administered. Vital signs would as well be important. Important medications, IV fluids, any emergency medications as prescribed. Some of the big ones that they need: antibiotics, bronchodilators, O2. Provide chest physiotherapy, because again, if that water got into the lungs, think about it in the sense of just like pneumonia or aspiration pneumonia. Something went into the lungs that didn't belong there. So now you've got nice, warm, moist area in that lungs, great breeding ground for bacteria. So you want to do all the same things we'd be doing with some of these other disorders to try and prevent further complications. So again, that's why the antibiotics are usually done prophylactically. Again, O2 because the oxygen exchange isn't that as good as it should be. The chest physiotherapy, break anything up, any of that fluid that's up. Turning would be important as well, making sure we turn that child every 2 hours if they're on bed rest. Incentive spirometer, if they're awake, they're not intubated, we need to make sure we're encouraging deep breathing and use of the IS every 1 hour to help aerate those lungs and prevent accumulation of fluid. We don't want any fluid to settle because, again, makes a great breeding ground for other infections. And the big thing is they just need to be monitored for complications for 24 hours after the incident. Because again, some things don't, even if they're revived on scene, some things don't show up until a little bit later. So again, they need to be observed. We're worried about cerebral edema, respiratory distress, and things like that. It'd be important also to discuss the child's fears and encourage that child to express their feelings to be able to help deal with the situation and process their feelings. When it comes to teaching, we want to instruct parents that even a small amount of water can lead to an accidental drowning. It really doesn't take much. It only takes maybe a few inches of water for a drowning to actually occur. It doesn't have to be in a pool. It doesn't have to be even in a bathtub, or it can be in a bathtub with a small amount of water. It doesn't take much. Really, just like I said, a few inches, and it only takes a matter of seconds for something to happen. Again, making sure parents don't leave children unattended when in a bathtub or a swimming pool. They need to be supervised. And encourage parents, especially of toddlers, to lock toilet seats when their child is at home. Toddlers are fascinated by water. They love to play in it. They don't care where it's at. They don't care if it's a toilet. They don't realize that that's, dirty and somewhere that you don't go play in. They just see water. So putting those locks on there, again, because it'd be real easy for a child potentially trying to reach in, play with the water, or reach in after something to accidentally tip into the toilet and then have a drowning or near drowning experience. It would also be important to instruct parents to make sure private pools are fenced with locked gates, trying to prevent children from wandering into those pool areas. So it really goes back to, those unintentional injury and safety prevention measures that we teach parents back in growth and development. And encouraging parents to provide life jackets when boating. So on the next slide, I also have just some water safety tips. A lot of this is things we've already talked about. There might be a few different ones, but just some other water safety things to think about. Last topic we're going to talk about is sudden infant death syndrome, or often referred to as SIDS. It is a sudden, unexplained death in infancy. It cannot be predicted, it cannot be prevented, it is unexpected and unexplained, so the cause is unknown. Epidemiology, peak age is between 2 and 4 months of age, and it occurs during sleep. So for your blank, occurs during sleep. There are possible contributing factors such as sleeping prone, a viral respiratory or botulism infection, exposure to secondary smoke, pulmonary edema, brainstem abnormalities, heart rate abnormalities. Again, not exactly sure why, but those are some possible contributing factors. Another big piece of this, which we've kind of already hit on some of it, high risk with prone sleeping position, for that first blank, prone sleeping position, soft bedding, overheating, and co-sleeping, for that last blank, co-sleeping with an adult. Some protective factors, breastfeeding, room sharing without bed sharing, so meaning they're either in a bassinet or the crib in the parent's room, but not in the same bed with the parent. Keeping up with routine immunizations. Avoiding soft bedding, overheating, that exposure to tobacco smoke, alcohol, or illicit drugs. The reason we say alcohol or illicit drugs, again, those interfere with decision-making abilities for an adult. So avoiding those things, obviously keeping head a little more clear, can be helpful. Pacifier use could be protective factor as well. And of course, we've already learned back in growth and development, we always place the infant back to sleep, so placing them on their back. And they also need to have a firm sleep mattress or sleep surface. So again, we know with babies' mattresses or cribs, they have a firmer mattress compared to an adult. The nursing care is directed really at supporting parents and family. Parents often, maybe their baby hasn't woken up in a while or should have been due for a feeding, or the parent goes in to check on them and unfortunately finds them unresponsive in their crib or whatever, their bassinet or pack and play, whatever they have them in. and usually call EMS because rightfully so, they're panicked. Um, but parents will usually end up, the child will still be brought to an ER, and the parents will usually be brought to the ER or will follow to the ER. And when they arrive, we really need to do a lot to prepare the family um, for what potentially their infant may look like. In the home, when they discover them, obviously they probably have clothing on, or in their panic, they maybe didn't notice some other things. So before we would take the family in, we would certainly want to prepare them for what the baby looks like. We would want to provide a room for the family to be alone in with the baby. Um, and not that you have to hover in the room the whole time, but staying close by to the room, being available, and kind of sticking close to the family, but still giving them that time for privacy to allow them time with their infant, even though the infant is deceased, time with that infant to say their goodbyes, hold them, whatever they need, have other family come in to say their goodbyes. Again, that's why we'd want to provide a private room if at all possible. We all, again, want to prepare how that infant may look and feel, that the baby could be kind of bruised and blanched, and that's really due to the pooling of blood, depending on how long that baby actually had deceased. Um, they may also feel cold. They're not going to have a warm body. So, again, preparing that family for that. An actual diagnosis of SIDS can only be determined by an autopsy. And what that will show is petechiae in the lungs, mild inflammation and congestion in the respiratory tract. And sometimes that autopsy report really gives the parents kind of some peace of mind knowing that there's nothing that they did wrong, that the death was really unexplained, and it wasn't their fault. That it didn't matter, that they didn't go in sooner, or how they dressed the infant or how they put the infant to bed. If they've taken all those other precautionary measures that we talk about, putting them back to sleep, not having loose blankets and soft bedding and things like that in the crib, this can really kind of give them that peace of mind that we don't know why it happened, but that it is something that does occur and it wasn't their fault. So, can I say that they would ever be completely fine with it? No, the death of a child is difficult, especially anytime, but when it comes as such a surprise, again, that autopsy report can give them maybe at least a little sense of um, relief that there was nothing else that was had to do with things that they were doing in caring for the infant, that it again wasn't their fault.